Thank you, Dr. Cornelius, and thanks everyone for participating in the polls. Again, given the answers you have selected, please pay close attention to the presentations and see where your questions are being answered. And where they have not been answered, you can ask questions at the end. If you have any new questions or additions, please add at the end of the talk. So let's welcome the first presentation of the day. We have Dr. Winnie Atala. She'll be taking us through the relevant applied renal physiology. And Dr. Winnie is an anesthesia resident in year 2 at our department. She'll be taking us through the same topic already. So Dr. Atala, the floor is yours.
Thank you so much, Dr. Erasmus, and thank you everyone for joining this discussion. Dr. Erasmus has already introduced me and my name is projected up there. I'm going to be talking about the relevant applied renal physiology, and I'd like to go share the outline. Just a second. I'll be briefly talking about the renal anatomy, the blood flow to the kidneys, filtration process, secretion, selective reabsorption, fluid and electrolyte balance, acid-base balance, renal autoregulation, and then interaction of the kidneys and other body organs. So talking about the anatomy, we have 2 kidneys, ideally. However, some people have 1, and they are retroperitoneal organs, and they're bean shaped. Each kidney weighs about 150 grams, almost a size of a clenched fist. And when you bisect the kidney, that's the diagram we're seeing here. And yeah, so we have the kidney has an indent that where we have the renal artery, renal vein, the ureters leaving the kidneys, the nerves enter into the kidneys. Then we have 2 regions of the kidney. We have the outer cortex and then the inner medulla. The inner medulla has a lot of functional units. We have the lobes, which are pyramid shaped, and we call them the pyramids of the kidney, and that is where we find the nephrons. Each pyramid has a number of nephrons, which are the functional units of the kidney. And as we can see here, that is a nephron that is within the renal pyramid. And yeah. And then when we look at the blood supply to the kidney, so the anatomy is quite brief, but I think you can see more from the diagram. Looking at the blood supply, the kidney is supplied by the abdominal aorta, and we have the renal artery, which is a branch of it. So it enters the kidney via the hilux, and it gives off branches in between the pyramids, and we call them the interlobar arteries. Above the pyramid, almost at the junction between the medulla and the cortex, we have these arteries that are running horizontally. They're called the acute arteries. The acute arteries then give off branches which look like the moving devices of the millipede, and that gives us the interlobular branches. So when you look at the diagram, hope you can see my pointer. This is just an extrapolation of one of the pyramids. This is what we see. We have here the acute arteries, which is branching off to give us the numerous interlobular artery. Now, this ball-like substances that we see in here is the glomerulus and then the Bowman's capsule. So the acute arteries give rise to the efferent arteriole that feeds into the Bowman's capsule, giving the glomerular capillaries, and then it leaves as the efferent arteries, and this now goes and gives rise to the peritubular capillaries that drain into the veins, and the veins move parallel to the arteries. So we have the interlobular veins giving us the acute veins, and then renal vein and brings into the systemic circulation. And then we have the interlobular arteries. They're those that go deep into the medulla. Up here is the cortex, and then we have the medulla region. And these ones give rise to the vasorectal capillaries. And we'll see the importance as we continue with this discussion. So this is what the glomerulus looks like. We have the efferent arteriole that comes in here, and then getting out is the efferent arteriole. Then when you look at the cross-sectional view of the glomerulus, here we have just around there, okay? We have special cells that are called the juxtaglomerular cells, or the Jejji cells, which have a lot of functions. We are going to further discuss them. And then also in the distal tubules, we have macular denser cells, which are also important in regulation of water and electrolytes. We are yet to discuss all that. Okay, so looking at this, we have the renal cortex and the medulla. So we have the blood supply. This is the acute arteries that are running in, then the giving of the interlobular branches. Now we have two types of, not necessarily two types, but in the region in which they are located, we have the corticonnephrons that are mainly situated within the cortex. They have a short loop of Henle that goes into, that projects into the medulla. Then you have the medullary or the juxtamedullary nephrons with a long loop of Henle that is mainly penetrating the medulla. And then we have the vasa recta, which is very important when it comes to reabsorption and the rest of the physiology. So shall look at each of these functions of the kidney: the excretion of waste product, regulation of water and electrolyte, regulation of body fluid osmolarity, regulation of arterial blood pressure, acid base, erythropoietin. We're not going to go into the detail of which, and then all these other functions shall be discussed. So, to start with, the first important aspect of renal function is the filtration. We have the blood supply is between 20 to 25%, on average 22% of the cardiac output. That's approximately 1,100 ml per minute. And half of this blood flow participate in filtration, and the other half just passes by. So half of which is about 625 mL per minute, which is going to participate in the filtration. And this here we have the filtrate. Only 20% of the 625 mL is filtered, and that brings us to 125 mL per minute, approximately 180 liters per day. Although most of it is reabsorbed and we have very little left for excretion. Now, the substances that are filtered have certain characteristics. For example, the low molecular weight materials are easily filtered. We're talking about water, glucose, electrolytes, urea, creatinine. The large molecular weight, for example, proteins, the red blood cells are not filtered. That's why it is abnormal to find these materials. And then the glomerular capillary membrane is negatively charged. So negatively charged substances are usually repelled. For example, the proteins are not filtered. Then positively charged materials are easily filtered, including the electrolytes. So we have the determinants of GFR, that is glomerular filtration rate, is determined by the balance of hydrostatic pressure acting across the capillary. And then what is common with every membrane that participates in diffusion or transfusion is the permeability and the filtering surface area, what is known as the capillary filtration coefficient. Okay, talking about the pressures, which is so important, we have the glomerular hydrostatic pressure, which is about 60 millimeter and 60 millimeter mercury, and this is provided by the renal blood flow. And then, as I said, proteins are not filtered, so they create an osmotic pressure along here. And remember, they are going to pull water towards themselves. So that creates a sort of resistance to the downward flow of the filtrate. And we have the Bowman's capsule pressure that is due to fluid accumulation, and it creates a pressure there. The filtrates themselves is able to create pressure. Now, in certain clinical medical conditions like diabetes or hypertension, you're going to have increased glomerular hydrostatic pressure, or in hypotension, the glomerular hydrostatic pressure is reduced. And then in the Bowman's capsule pressure, when you have hydronephrosis of any cause, maybe a tumor or stones in the ureters, there's buildup of fluids and hence buildup of pressure, and that is going to inhibit the filtration. So we have one force that is acting against two, and that gives us the net filtration pressure, that is the glomerular hydrostatic pressure minus the combination of these two pressures. And if the glomerular filtration pressure is greater than the two forces that are acting against it, then filtration is facilitated. When the Bowman's capsule pressure is elevated, filtration may not be possible, and that is how obstruction causes AKI and the rest of the kidney injuries. We look at the renal tubular reabsorption and then in fluid and electrolyte imbalance. I'm going to using this diagram. As I've said earlier, the number of substances that are filtered, the electrolytes, water, glucose, and we have tubular secretion, like the amino acids and the bases and the acids like hydrogen ions are secreted into the tubular lumen. In the proximal convoluted tubule, where most of the reabsorption takes place, it has very nice characteristics to favor that. One, it has a large surface area. It's highly metabolic, so production of ATP that is used in active transport and all the other characteristics. So we have the electrolytes being absorbed, the sodium, most of the electrolyte being absorbed at about 60%. And then water is obliged to follow the solutes. The loop of Henle has the three parts, the thin descending, the thin ascending, and then the thick. Now this part is almost impermeable to most of the things because of the low surface area for diffusion and also the low amounts of ATP that is being produced. As we go on the thick ascending, reabsorption gets better. So we have about 25% of sodium chloride being reabsorbed. Magnesium, calcium are highly reabsorbed along this thick ascending. Until in the distal tubule, we have absorption of sodium chloride. When we have low calcium in serum, there is a production of the parathyroid hormone that increases reabsorption of calcium, of calcium. And then in the distal convoluted tubules, we have the distal part of the convoluted tubule. We have specialized cells, the principal cell that is so important in the absorption of sodium, water, and excreting potassium. We have the intercalated cells involved in secretion or reabsorption of hydrogen, bicarb, and potassium. We're yet to discuss that. And then in the collecting duct, that's where the action of the ADH is pronounced, where it causes opening of the aquaporins and reabsorption of water. We're going to discuss most of those ahead. Okay, yeah, the secretion, I've already talked about it. Looking at the acid-base regulation by the kidney. Okay, this is the tubular cell, and then the tubular lumen and the renal interstitium. So we have metabolism that is taking place and producing carbon dioxide. When carbon dioxide enters the cell, it binds with water, forming carbonic acid, acted with the help of the carbonic anhydrase. And this produces bicarb and then hydrogen ions. The bicarb is reabsorbed using the bicarb sodium bicarb co-transporter, and the hydrogen ion is excreted. The rate at which bicarb is reabsorbed and hydrogen ion is secreted depends on the body's demand, whether you have metabolic acidosis, metabolic alkalosis, respiratory acid-base disturbances. That's what determines the absorption of them. And the hydrogen that is secreted into the tubular lumen binds to the filtered bicarbonate to form carbonic acid, which breaks down into carbon dioxide and water. Carbon dioxide is taken back into the cell, and then water is excreted. And then we have buffers. Now that hydrogen ion is filtered out, rather is secreted, it has to be excreted, and it's usually excreted bound to certain electrolytes, for example, the phosphate. So you have it here binding to phosphate, and then it's excreted, like the buffering system. Then also in the distal tubules, we have ammonia that easily diffuses out into the tubular lumen, and this also binds to the secreted hydrogen ion, forming the ammonium, which binds to chloride, and then it's eventually excreted from the body. Ammonium is not able to cross back into the tubular cells. So these are the factors that determine how much hydrogen ion is secreted and how much bicarb is excreted. I've already talked about the metabolic disturbances. We have the decrease in extracellular fluid volume, factors that are going to increase hydrogen ion secretion. So when the extracellular volume is reduced, and there's activation of the renin-angiotensin system, and angiotensin and aldosterone causes secretion of more hydrogen ions. And then hypokalemia also increases secretion of the hydrogen ions. And then here is the opposite of what took place the other side. Looking at autoregulation of GFR and renal blood flow, this is where most of the physiology occurs. This is to prevent fluctuation in the GFR with fluctuation in the arterial blood pressure, because the blood pressures are never constant. Just like the brain regulates its blood supply, so does the kidney. We have the autoregulation normal ranges, I think, is between 70 to 180 of arterial pressure. So it has a wide range to maintain a constant GFR. So we have a number of mechanisms, the intrinsic mechanism and extrinsic. The intrinsic mechanism, we have a myogenic mechanism, glomerular feedback. Looking at the myogenic mechanism, when the renal blood flow is high, it causes stretching of the afferent arterioles, and this causes sodium to enter into the cells, and then you eventually have the release of calcium from the endoplasmic reticulum, and eventually have vasoconstriction. That's how it works. So when vasoconstriction takes place, there's definitely going to be a reduction in renal blood flow, and then hence GFR. And then the opposite happens when the when the blood pressure is low and there's less stretching of the afferent arteries. Then the tubuloglomerular feedback. This is about we have special cells that are called the macular denser cells. Now, increase in high blood pressure will lead to increased renal blood flow, hence increase GFR, and increase in the filtrate that enters the tubules. Now, when the filtrates reach and reabsorption is not going to be adequate to take out each and everything. So quite an amount of the solutes are going to reach the macular denser cells, which are sensitive to them. And the macular denser cells are going to send feedback to the it's going to send feedback to the efferent arterioles by releasing chemicals that cause vasoconstriction or chemicals that that would cause vasodilatation. For example, it releases adenosine that will cause vasoconstriction of the efferent arterioles, and then reduces the production of nitric oxide that would rather cause vasodilatation, hence reducing renal blood flow and GFR. That is the tubuloglomerular feed. And then we have the extrinsic, like the sympathetic nervous system. This takes place in the heart. In the heart, we have the aortic and carotid baroreceptors that sense the stretch. So the higher the blood pressure, the more the stretch, the lower the blood pressure, the less the stretch. And this occurs in hypotension. And the signal is sent to the brain via cranial nerve 9 and 10, and the brain activates the sympathetic nervous system, which then sends feedback to the sympathetic nervous system can come back to the heart, and with release of epinephrine and norepinephrine, stimulating the beta cells to increase cardiac contractility and heart rate. And then they also act on the alpha-1 receptors, causing vasoconstriction. And the net effect of this is to increase systemic blood pressure. At the same time, the sympathetic nervous system will go into the kidneys. In the efferent arterioles, we have the Golgi cells that release renin, and there is activation of the renin angiotensin aldosterone system. And its net effect is to increase water and salt retention, to increase the blood pressure and improve renal perfusion. We have the RAS system, and this goes back to the diagram I shared about the reabsorption and secretion. So the number of factors that activate the renin angiotensin system, the Golgi cells, the juxtaglomerular cells, contain baroreceptors that stretch, or when they're stretched, they're going to cause vasoconstriction. And when there's hypotension, they will release the renin, and then we start the cascade of renin angiotensin. We also have the central nervous system and the sympathetic nervous system, as I have already discussed. The macular denser cells are also stimulated. When they're stimulated due to the low solutes that is reaching it, it also causes the Golgi cells to release renin. And we have this cascade of angiotensin 1 and 2. Now, angiotensin 2 has a number of effects to help increase the water and salt retention. First of all, we go into the aldosterone, causing water and salt retention. At the same time, it stimulates the posterior pituitary gland to release ADH, which ADH is going to act on the collecting duct, increasing its permeability to water, because it's poorly permeable to water, but can only be permeable under ADH influence. Then it also stimulates the thirst center, increasing water intake. At the same time, angiotensin 2 increases systemic vasoconstriction, and that increases systemic blood pressure, hence improving renal perfusion. And then it also causes vasoconstriction of the efferent arterioles. The efferent arterioles are on the other side. So when you create a higher pressure on the exit, it increases the filtration, the GFR, because now the blood can't leave the glomerulus until much of it is filtered. And then, okay, this is almost the last bit. We have the renal interaction with other organs. We have the cardiorenal interaction. We have the natriuretic peptides, the ANP and the BNP. Now, these hormones are secreted when there is overstretching of the atrium and the ventricles that occurred during heart failure. And release of them is going to cause the net effect is to reduce salt and water retention. So what they do is one, they cause systemic vasodilatation to decrease blood pressure, hence renal perfusion. At the same time, they cause a decrease in renin secretions and the blunting the effect of the angiotensin too. And yeah, so it reduces mainly salt and water retention, improving diuresis and reducing the cardiac fluid overload. It also acts via I've already talked about the sympathetic nervous system, where there is a stretching of the baroreceptors and there is feedback to the kidneys. The neuronal interaction, we have the ADH, whereby one is regulated by the plasma osmolarity. When the plasma osmolarity is high, that means there is less plasma volume. It is sensed, and this causes the release of ADH from the posterior pituitary gland, and it acts on the collecting duct. Then also angiotensin 2 release. And we have the sympathetic nervous system that I already talked about. Angiotensin 2 also causes release of ADH, as earlier discussed. The hepatorenal interaction, and this usually occurs when there is hepatic disease. For example, the liver cirrhosis causing portal hypertension and release of the nitric oxide, the vasodilators. It basically occurs almost in every part of the body, and that's the same mechanism by which you get the hepatopulmonary hepatorenal syndromes. The nitric oxide causes both systemic vasodilatation and the GI circulatory vasodilatation, and this eventually result in a renal hypoperfusion. Yeah, and that gives you the hepatorenal syndrome. So the patient goes into AKI and eventually CKD if the hepatic disease is not well managed. Okay, yeah, okay. That brings me to end of my presentation, and I would like to give the floor back to the moderator. Thank you.
Yes, thank you very much, Dr. Tala, for that concise rundown of physiology, quite a broad subject. The kidney being an organ means there's a lot to talk about in there. So we have about 5 minutes to run through some of the questions that you might have. So kindly raise your hand and then you'll be selected. If you have any question, any addition, an inquiry. Okay, so in the meantime, I would like to acknowledge the participation of our colleagues from, there's a colleague from UVRI, Dr. Abu Bekar, who's representing UVRI as part of the audience. Then Usitema, Dr. Ocheng, and the team. I hope your trainees join us every now and again. Semanda, Huntington, our main export to Kenya, Aga Khan Hospital. It's also part of the team. I guess you're welcome. Thanks so much for your active participation. Do we have any questions on this particular talk? In the meantime, as we think of questions, Dr. Cornelius, would you like to run maybe another poll, maybe for the next talk that we're going to have?
Okay, so thank you very much, Winnie, for that presentation. I think Winnie covered all the aspects of the polls, and I hope that the audience was able to deduce. So I think before we go into the next poll, I will quickly share what the results were for the first poll, and the answer is 20%, so 80% were correct on that. And then for the next poll, that was about proportion of renal blood flow that is filtered, again, it's 20%. So the quicker way to know this is 20%, 20%, you'll probably be correct. And then the final one was about whether renal blood flow is autoregulated like cerebral blood flow, and the answer here, because it was a negative, is not regulated. Those who selected no were actually correct.
I thank you so much, Dr. Cornelius, and again to the audience for the participation. We shall get again answers to this hopefully during the talk, and if there's any area of discussion, we shall have at the end of the presentation. So first, again, acknowledging participation from a colleague from Moi University. He's an internal medicine registrar, Dr. Bashir. You're welcome. So back to the next talk. Dr. Bernard Oyang is an MD Anaesthesia resident in year 2. He'll be taking us through a clinical case of that's representative today that really bears the subject of the conversation today for acute kidney injury. And then he will take us through the epidemiology of acute kidney injury in the critically ill. Dr. Oyang, over to you. You have 15 to 20 minutes for your talk, and thereafter shall have questions and answers. Thank you.
Thank you very much, Dr. Rasmus. I will lay emphasis on the clinical case that I'm going to present. But as you look at the brief outline, I'll highlight briefly the epidemiology of acute kidney injury in our setting, and then talk about the case, and also highlight some issues relating to the outcomes of acute kidney injury. So in terms of epidemiology, generally they look at the epidemiology of acute kidney injury in two aspects. Those that are hospital associated, as well as those that occur mainly in the community, what is described as community acquired. So in the developed world, acute kidney injuries predominantly occur in the hospital setting. And about 5 to 10% of general hospital admissions actually do end up developing acute kidney injury. And in those countries, most of the cases occur in the older patients. The main causes are related mainly to surgical and diagnostic interventions, as well as other iatrogenic factors, maybe we know of contrast and other forms of radiotherapy that can be nephrotoxic. About 50% of all patients in the intensive treatment units usually develop AKI, where the AKI itself acts as an independent risk factor for mortality of about 20 to 60%, depending on the stage, because you know there's stage 1, stage 2, and stage 3. So mainly it's in the ICU, AKI is seen as a spectrum of the debilitation in a patient with multi-organ dysfunction, and the mortality is quite high. In the community, the Kidney Disease Improved Global Outcome Consortium does estimate that there is a worldwide AKI prevalence of about 2,100 or 2,100 per million persons, and the majority of these cases do occur in the community, as I mentioned, and these are mainly in the developing world. And some of the reasons highlighted for this large proportion is because of the poor access to care that we are aware of, but also we have plenty of infections associated with sepsis. In some cases, volume depletion due to a couple of reasons, and then toxins due to maybe bites and other forms of therapies, including herbal remedies, which are not well evaluated. But also some of the other contributing factors, especially with regards to sepsis. It's documented that about 20 to 25% of patients who have been diagnosed with sepsis do have AKI. And in the setting of septic shock, it is as high as 50%. In our setting, it's not only in the old, but in the younger population. Actually, the majority of the cases are found in the younger population. People who have chronic kidney disease usually at an increased risk of acute kidney injury, and actually AKI is a risk factor for poor prognosis. Or, in patients with chronic kidney disease, all the other issues that come on the heel of chronic kidney disease. So the incidence of dialysis-dependent acute kidney injury is about 200 persons per million annually, globally. Coming back home, quite a number of work has been done in the area of acute kidney injury and chronic kidney disease generally. But I highlight here only two cases, recent papers that have tried to throw some light on the current prevalence of acute kidney injury. So a study by Chimwere and other teams from Mbarara Regional Referral Hospital that was last year highlighted that the incidence of acute kidney injury in patients diagnosed with sepsis during a period of about 48 hours was at as high as 19.2%. Another study that I picked this year, this was in April, the publication was April this year, but this time in children, by Namazi and the rest of the team from the pediatric team here in Mulago, indicated that the prevalence of acute kidney injury was about 45.3%, with 21.5% of them having unresolved acute kidney injury after 24 hours. And this was data in a population from Eastern Uganda. And they went ahead and documented that survivors of acute kidney disease post-AKI actually had higher post-discharge mortality of about 18% as compared to children who did not have acute kidney disease. I'll highlight more on this when I conclude my talk on the outcomes or prognosis of AKI. So at this point in time, I would like to present to you a case of a 47-year-old male, a referral from one of the regional referral hospitals here in Uganda, who was sent to us here to our ICU in Mulago due to a markedly reduced urine output with worsening difficulty in breathing and a declining level of consciousness over a period of 48 hours. However, this was a known patient of hypertension for more than 10 years who had recently been started on Amloza, that's a combination of amlodipine and losartan. I highlight losartan there in bold because, as you know, someone will talk about it in the pathophysiology, is one drug that can be implicated as a cause of renal injury. And then he was also initiated on aprinox, that is benflumethiazide, indapamide, as well as metoprolol. Before this patient had been diagnosed about a year ago with hypothyroidism, and he had been on levothyroxine for supplementation, but this was stopped about some few weeks back before he presented here as a result of complications relating to hyperthyroidism. His doses were between 25 to 50 milligrams daily. The patient also had a recurrent history of anemias with multiple transfusions, although there were no clear documents for this at the time of admission. Recently, a diagnosis of multiple myeloma had been made, and also amyloidosis, pending confirmation by the heme oncology team. So this gentleman had been unwell for a period of about 1 year with recurrent symptoms of anemia, significantly reduced oral intake, and was really he had progressively lost his weight. About 3 days then, prior to his admission, he developed a rapidly decline in his urine output. In fact, over the period of 48 hours, his urine output in the urine bag that had, the urine bag for continuous bladder drainage was at less than 50 mils over a period of 72 hours. So the symptoms had been with him, and he was at the regional referral hospital. So he was referred actually for further management of renal dysfunction with the possibility of initiating him on hemodialysis. In the review of other systems, significant in the cardiovascular system, the caretaker reported occasional chest pain with associated body swelling, which had resolved by this time. In the musculoskeletal system, there was a history of progressive skin desquamation, especially on the face and the extremities. In his past medical history, he had had multiple admissions in private peripheral healthcare facilities that side with the treatment of what they describe as anemia and fevers. And although the documents were not right there with us to evaluate this information, he was HIV seronegative according to their report, and he had been started on low-dose Lasix over the period of 48 hours prior to his admission, 50 milligrams of IV Lasix once daily. In terms of his family social history, he was a devoted non-smoker, non-alcoholic, father of 2. There were no clear family history of any chronic illnesses in this patient. Upon physical examination, he was a very sick-looking middle-aged male, febrile to touch, with a moderate severe pallor of the conjunctiva, with a tinge of jaundice. He was severely dehydrated, but he did not have any evidence of cyanosis, peripheral or central. There was no digital clubbing, but he had what I queried as uremic frost on his face, as well as the upper extremities. In terms of the CNS, he had a low GCS of 13 out of 15 with eye opening score of 4, the best verbal response of 3, and the best motor response at 6. His pupils were equal and reactive to light. He had a globally reduced muscle bulk, but there were no obvious craniopathies in the patient. In the respiratory system, he was in mild respiratory distress with a rate of 28 breaths per minute. His oxygen saturation on room air was 94%. His chest was clear with equal bilateral entry of vesicular breath sounds. There were no added or additional breath sounds. In the cardiovascular system, he had warm peripheries. The capillary fill time was about 3 seconds. He had a normal volume, regular pulse with a rate of 98 beats per minute. He had no neck vein distension. The heart sounds 1 and 2 were had with no added sounds. Parabdomen or GITR, the scaphoid abdomen, which was soft, non-tender, and there were no palpable organ enlargement. The parectal exam was deferred at this point in time. In terms of the renal system, he had the urethral catheter in situ, and there was about 50 mils of clear urine in the urine bag. And the report we got from the team that transported him said he had received about 500 mils of normal saline en route our hospital. In terms of hematology, he had multiple petechiae and the chymosis, but there were no obvious gum or other orificial bleeding. In the skin and musculoskeletal system, he had multiple small bruises on the back as well as in the hip areas. The lab workup that he came with at this point in time from the referring unit, the RFTs and electrolytes, he had hyperkalemia of 5.2 millimoles per liter. The sodium was within the normal range, 140.7 millimoles per liter. Chloride was normal, 103.4. The calcium was mildly elevated at 11.2 milligrams per deciliter, but he had a significantly raised blood urea nitrogen at 170 milligrams per deciliter. Normal range you would expect between as high as 1.8. The serum creatinine was at 4.42 milligrams per deciliter. We only had one aspect of the liver function test. They only gave us in the referral note. Remember, I highlighted most of the documents were not with them at this point in time. So you had a hypoalbuminemia of 3.3. The complete blood count, he had a thrombocytopenia, significant thrombocytopenia at 58 cells per microliter of blood, and a moderate normochromic normocytic anemia of 10.5 grams per deciliter, hematocrit of 33.9, and then the total white blood cell counts were at 3.8 times 10 to power 3 times 10 to power 9 per liter. In terms of coagulation profile, he came with the results of platelet prothrombin time of about 14 seconds, and the INR was 1.18 seconds. There was a document for histopathology that reported myeloma CD138, which as being positive, and also a report of amyloid. That is exactly how it was in the document that we had. So we did a venous blood gas upon admission, which showed a metabolic acidosis, high anion gap metabolic acidosis with a pH of 7.16, bicarb of 11.2, and then with the hyperkalemia of 5.6, and then hyperlactatemia of 9.5. Sorry. So the issues that we had, as it is our protocol in ICU, we do not conventionally make diagnosis. We deal with the issues at hand. So we thought this patient had oliguria, in other words, oliguric AKI. He was a severely dehydrated patient with metabolic acidosis, low GCS, moderate anemia, and malnutrition. So our plan at that point in time that we should do a point of care ultrasonography, particularly to evaluate whether he was actually responsive to a fluid challenge. But as I'll highlight later on, this was not possible. We also wanted to do an arterial blood gas and the venous blood gas that I already highlighted the results, and also evaluate his thyroid function test so that we can actually have a conclusive discussion with the primary physicians that referred him. We also inserted a central venous catheter. We passed an NG tube and initiated his oral feed at 50% of his daily caloric requirement. We activated a multidisciplinary team, including nephrologists, cardiologists, and then the heme oncology team, to mention a few of the members. We were also working him up for possible dialysis. So our consult with the nephrologist, he recommended that we should stop the IV Lasix that he was on, and instead start him on oral lactulose, and then oral paromomycin, and then we continue with the other plans as we had initiated in ICU. He also recommended that we should have an urgent echo and ECG done before we could initiate him on dialysis. So he also asked the team to place a catheter, and indeed we had a catheter placed. So the point of care ultrasonography showed non-collapsible, what is sometimes described as a full IVC, and so we decided to withhold any fluids and instead increase his the fluid intake via the nasogastric tube. The other lab workups that we did that evening included the thyroid function test. These results we got the following day actually, that showed a TSH of 8.69 and then a free T4 of 0.99. So we were compelled to reinitiate the levothyroxine. Blood slide for malaria parasite was negative. Hepatitis B surface antigen was also negative, but significantly the hepatitis C virus antibodies were positive. So his progress while in ICU on day 2, this patient continued having worsening acidotic breath despite a normal oxygen saturation on room air. And then the urine output actually worsened in a period of the 24 hours that were 12 hours. Upon evaluation in the morning, he had only added about 10 mils of urine. So in a period of more than 72 hours, we had 60 mils of urine in the urine bag. The venous blood gas, if you track the acidotic breath in terms of the blood gases that we did, if you compare, just a second so I can have a pointer. Okay, so if you look down here, we had attempted to correct at least the metabolic acidosis, the pH on the 18th. The VBGs, the first one, is what we had on the 18th, showing the acidosis, but at least it had improved at 7.36. The hyperkalemia had also resolved. We were within normal range of 4.5. And the hyperlactatemia had also come down now to 2.62. But we still had a compensation. Of course, the bicarb was at 20.2. So I'll move on. In addition to the worsening acidotic breath, the patient's GCS continued declining. At this point in time, we had he was scoring about 10 to 12. And then he developed hemodynamic instability with mean arterial pressures falling below 65 millimeters of mercury. So we were compelled to initiate him on vasopressor support. We started with a noradrenaline infusion at low doses of 0.05 mics per kilo per minute. And we also started him on oral amiodarone because his ECGs were showing PVCs at a rate, I think, yes, PVCs in general. And then, like I said, we also initiated him on the levothyroxine, and then we started antibiotics on meropenem. The team that referred him said for 1 day, they had put him on epicephin. So we reintroduced, we escalated him onto meropenem. The other plan was that we stopped the lactulose and then the paramomycin and continued the rest of the management as we had initiated before. Later that morning, the multidisciplinary team consisting of the ICU team, the nephrology.
Dr. Young, your audio is muted, is off. We cannot hear you. Could you address that?
Thank you very much. My sincere apologies for the internet challenge, institutional problems. So I project this table, particularly for us to follow the trend that we had. I think the view is not excellent, but let me just, in favor of time, try and summarize my talk. So if you look at the information I've presented, the baseline here was on I think the 17th, or before the patient was referred. You look at the blood urea nitrogen, where it was, and when we came and we initiated our interventions, we came down on the 18th to about 90 milligrams per deciliter. The serum creatinine, however, went up after a period of about 12 hours. We had managed to bring down the serum potassium levels, as I highlighted earlier on, and then the other parameters are there. But the catch in this table is that you see lots of missing data, both from the institution where the patient was referred from, and then in our setting as well. These are challenges that we have in investigating patients, because you want to have as frequently as possible renal function analysis and liver function tests and other lab evaluation in these patients, but circumstances do not allow. The patient was sent only, in terms of the renal function test, only albumin had been indicated, as well as the coagulation profiles. And then in terms of this, and the CBC, of course, is one of the things that should be done in any institution. What I presented here is just to highlight the thrombocytopenia. This correction was without any administration of platelets to this patient. But just the message is that we have challenges with investigating the patients, and so it compromises on quite a bit of issues with regards to our treatment for these patients. So, as I mentioned earlier on, later on day 2, the patient was initiated on dialysis. The mode that was taken was the continuous renal replacement therapy, and it was still in progress. But we had challenges because the dialysis set, which of course is required in this machine, was running low, and we had to try and solicit from other facilities around the city. The patient's hemodynamics, though, was still being maintained on a combination of NORAD and epinephrine. The doses were going higher, but the patient still continued exhibiting acidotic breaths. So in the night, the breaths became worse. And then towards early morning, the patient went into hemodynamic instabilities with unrecordable blood pressures, but the infusions of, despite infusions of noradrenaline and adrenaline, and he went into a cardiac arrest, or what I described there as circulatory arrest. CPR was initiated, which was continued for longer than 2 hours, but there was no return of spontaneous circulation, and we lost to the patient. So I'll summarize in the next 2 slides by talking about the outcomes of acute kidney injury, or the prognosis, so to say. So AKI is associated with a significantly increased risk of in-hospital and long-term mortality, as well as long duration of hospital stay, and then of course the cost to the patient. Patients who have pre-renal azotemia, with the exception of those with hepatorenal and then cardiorenal syndromes, do have a better prognosis, and most of the patients in cases of intrinsic AKI. And it is actually a fact that the kidney may recover even after severe dialysis requiring acute kidney injury. So survivors of an episode of acute kidney injury requiring temporary dialysis, however, at extreme risk of progressing to chronic kidney disease, and up to about 10% actually may end up developing end-stage renal disease. That's why it's important that on discharge, most of the patients should actually continue being under the care of a nephrologist, as well as the other members of the multidisciplinary team. In terms of mortality, acute kidney injury-related mortality still stands at about 23% globally. The patients who have acute kidney injury are more likely to die prematurely upon discharge, and this is mainly related to issues within the complications within the cardiovascular system, but also cancers. That is where my presentation is stopping, and my apologies again for taking a bit longer. Back to you, moderator, Dr. Erasmus.
Thank you so much, Dr. Oyam and team. I would like to welcome questions to the talk. Our first question coming in is from Dr. Agawa. He is asking if this was actually acidotic breathing the patient was exhibiting, or just enteroneurogenic hyperventilation, given that from the blood gas you did, the acidosis was fairly well compensated. Perhaps, Dr. Gaba, the question would be about the timing of the test and the time when the breathing was noted. I think the blood gas was done in the evening. Before the night when the patient deteriorated. So I wonder, maybe the breathing was a mixture of things. This patient also had evidence of heart failure. So what we're seeing as maybe the acidotic breathing could be a mixture of all types of respiratory patterns, including chain stocks, among others. I don't know if the team on the ground was able to make a correct diagnosis of what type of breathing it was. But yes, as the patient progressed, I think the patient became more hemodynamically unstable. So you can imagine maybe lactic acidosis, hypoperfusion of the brainstem and the like. So definitely you could be right as well, as that could be a contributor. Thank you. Dr. Fred Bulamba, could you ask your question? Yes, unmute and ask. Dr. Fred Bulamba, could you unmute and ask your question? Any other questions?
Okay, it has allowed me. Thank you. Initially, I wasn't able to. Thank you for your presentation. One of the challenge that the dilemma that us who work up country face is as regards at what point the receiving hospitals would like us to send these patients with AKI. Maybe the presenters that are going to speak might touch on that, but at what point would you have wanted to receive this patient, and what can you advise us as regards when we should be sending patients in whom we suspect or in whom we've diagnosed AKI? Thank you.
Okay, thank you so much, Dr. Freddy, for that question. We shall hopefully answer it as we go. Dr. Owor is asking, please clarify on IVC collapsibility, fluid status, and modification of fluid plan for the above patient. So Dr. Oyang, could you just respond to that? I guess you can start with Dr. Caesar's question. Please clarify on IVC collapsibility, fluid status, and the modification of fluid plan for the patient. And then we can reserve the other question from Dr. Blamba maybe for the next speakers as we proceed.
Thank you very much, Dr. Rasmus. Sorry, a bit of feedback. Shall I proceed?
Please answer the question, Doctor.
Okay, so Caesar was asking me what the value, I think, and he wants the actual diameter of the IVC. I do not have the figures offhand, but what I can say about why we did this focus, and particularly we're interested in looking at the diameters and perhaps the collapsibility of the IVC is that this is one of the bedside tests we can actually do to evaluate if a patient is responsive to fluid therapy. And in the setting of acute kidney injury, you want to be sure that the patient will respond. Of course, you can do a passive leg raise and all the other features. But one of the quick things, we had the ultrasound machine with us, so we could actually do a focus. And when you see that the IVC, the walls are not kissing, that means the patient is not responsive to fluid therapy. And so we deferred, and as I mentioned, we actually diverted most of our fluid because the patient was dehydrated to give it via the NGT. So it's a bedside measure that we can actually use to evaluate if the patient is fluid responsive or not. And in this case, we wanted to challenge the kidneys with some bit of fluid before proceeding to other forms of management. I hope that's fair, or Dr. Rasmus can add on that. The second question, like he said, I'll reserve it for the subsequent presenters from Dr. Fred Bolamba. Thank you.
Thank you very much. So just to clarify, generally, we don't have a good tool to tell us about the fluid status of a patient. We don't have that. So it's a misnomer that commonly appears in the literature. Someone says they're using an ultrasound to diagnose fluid status. That is wrong. We cannot do that except if we were to bleed and dehydrate the patient completely. Instead, we can assess the interaction between the heart and lung, which tells us about the heart function and the intravascular pressures and the dynamic interaction. That tells us that the patient would otherwise benefit. In other words, their cardiac output will improve if given fluids or not. So definitely assessment of IVC, collapsibility, the VTI, passive leg raise, among other things, really, pulse pressure variation, among other things, really just give us an idea of that interaction. But on top of everything, if you look at the story of this patient, the fear that he had multiple myeloma also made us look out for other possible complications of multiple myeloma, including a myelodeposition in the heart. So we really wanted to rule out things like heart failure at the beginning. So basically the focus was done to look at the heart, then look at also the vessel, the major vessels. And as Dr. Young said, the heart was quite distended, all the chambers were quite distended, and the contractility wasn't the greatest. The IVC was quite plump in this case and not varying so much. We don't really know what amount of IVC collapsibility predicts fluid responsiveness in patients who are not intubated and paralyzed. The validation of IVC collapsibility was done in patients who are sedated, intubated, on controlled ventilation, then as they are also paralyzed. So in that case, we're looking at the variability of about 12 to 15%. Anything more than that would predict the patient, given fluid, would respond. However, in the patients who are spontaneously breathing, either on vent or off vent is difficult to tell. Some studies have looked at patients who are breathing spontaneously on vent and looking at a 50% variability of the IVC. So we extrapolate the same to the patients who are not intubated, but there are lots of caveats. So at the end of the day, it's really a collection of clinical signs here and there to tell you what's happening. In this particular patient, examination of the heart was the first thing to tell us how the heart was functioning. It told us that the heart was not very happy with an extra fluid loading. The second thing was the IVC being plump, of course, told us that maybe it would not benefit from any further fluid loading. And I think the team thought about fluid restriction, now taking away all IV fluid and hopefully just maintaining them oral fluids if the patient could absorb that. Definitely, again, all these assessments are dynamic. I don't want to take long on that question. So the next question was, how's RBS? How's the RBS? What was the level of thyroid hormone levels? Could amiodarone have worsened hypothyroidism? Did the GCS change on treatment? Was this an AKI alone, or was it AKI on CKD? How was the abdominal ultrasound find and kidney size? Dr. Semei has many questions here. Dr. Young, would you like to take on these questions?
Thank you very much, Dr. Rasmus. I'll just take on from where you stopped. I see Dr. Mata was also asking the findings of the echo and the POCAS. Actually, it was an oversight. I didn't show the results here. The cardiology team did an echo, and they found that the patient actually had an ejection fraction of 35%, which was way below what is expected. And also they highlighted that he had infiltrative cardiomyopathy with the left ventricular systolic dysfunction, although they didn't quote the grade. And of course, the other IVC issues, just like Dr. Erasmus mentioned, was as per the POCAS finding. Semei is asking me, I think, one of the questions I saw is with relation to a culture, if at all any culture was done in this patient. Well, we took off a sample on day 2, but remember what happened to the patient could not allow us to get even the preliminary results, which usually we want to get in about 48 hours. So we did not have any culture results to guide our antibiotic therapy in this patient. The other questions, Dr. Rasmus, if I may continue, I see Dr. Cornelius asking me why the team did CPR for 2 hours in a patient with multi-organ failure, and what was the initial rhythm of arrest, and what were the sequential rhythms in the arrest. I have my colleague with whom who was at the scene during the resuscitation, Dr. Sophia. Maybe she could highlight what happened during this moment.
Good evening, everyone. So the initial rhythm was a systole. Unfortunately, I was not around, but the nurse said the patient had some bradycardia and then went asystole. So the sequential rhythms during the CPR, the whole process of resuscitation, we had just one episode of a VTAC, but at that moment, we didn't have a defib, and the rest of the other reasons were just asystole still, and our pulseless electrical activity. That was it.
Okay, thank you, Sophia, for that supplement. I see other subsequent question was it the right decision to dialyze the patient at the time when the patient's vitals were unstable? I think I'll reserve that. Maybe Dr. Rasmus will make a comment on that. Was the patient on anticoagulants? No. The records that we had, and while the patient was with us, we had not yet initiated the patient on any anticoagulants. Dr. Fred says it's impressive that the patient had been put on, we had activated the input of a multidisciplinary team. But in what time did you manage to get all this team to see the patient, or were they on phone? All the teams that I highlighted as part of the multidisciplinary team actually saw the patient physically, and they had a discussion, I think, on 2 days. And their plan or their intervention, their recommendation is what I highlighted in part of my presentation. Dr. Hannington is asking, wait.
No, it's okay. It's okay, Dr. Young. So gentlemen and ladies, thank you. We are running out of time. What we're going to do is let the questions continue to come through in the chat. We shall be answering them as we proceed. I guess the first one that really need to make a clarification on is that, about 24 hours prior to patient's demise, this patient was throwing a lot of PVCs and was having runs of VT, non-sustained VT. So that is why we initiate the patient on amiodarone. It is unlikely that we did have the IV amiodarone, so went with the oral dosing of amiodarone, which helps to suppress the VT runs, can return to sinus rhythm entirely for the rest of the run before the cardiac arrest. It is quite unlikely that that short time, that 24-hour window, was enough to cause him to get worsening hypothyroidism. In terms of the cardiac arrest itself, it's difficult to say. There was no PE in this patient. Of course, about anticoagulation, initially the patient was on DVT prophylaxis on arrival because he was bleeding from lesions on his back. But definitely when we put him on dialysis, we had to put him on anticoagulated dialysis, so he was getting anticoagulant through that route, and there was no complication from at least the bleeding perspective during dialysis. We did CRRT for the patient. It's quite gentle and he tolerated fairly well. Initially, he was requiring vasopressors, and actually there's a point when he went off vasopressors, or at least went to very minimal levels of vasopressors. What was very clear is that the patient had cardiogenic shock rather than, vasodilatory, because when he was on Norep alone, increasing dose of Norep were causing him to get into further hypotension and shock. So we had to introduce adrenaline, and with introduction of adrenaline, we were able to improve perfusion and actually lower the requirements quite significantly for the next 24 hours before the cardiac arrest. Dialysis was done to help to address the issue of acidosis, hyperkalemia, and fluid overload that was having. We shall be answering the rest of the questions as we continue, but thank you very much. Keep them coming. All right, so for now, I would like us to proceed the next talk. So our next speaker is Dr. Sophia. Dr. Sophia is an anesthesia resident. Sophia Namwaya is an anesthesia resident in year 2. She is going to take us through the pathophysiology and diagnosis of AKI. So let us give her our due audience, and we shall continue with the questions as we go. Thank you.
All right, good evening, everyone.
Good evening.
I am Sophia Namwaya, anesthesia resident in year 2. I'll be going through pathophysiology and diagnosis of AKI in the critically ill. We're going to start off with the diagnostic criteria, since previous speakers have not yet mentioned it anywhere in their presentations. So we have 2 kinds of diagnostic criteria that we'll talk about, that is the rifle and the Akin. The rifle is a mnemonic for risk, injury, loss, and end-stage renal disease. And we have different parameters that we use to assess all this. We have serum creatinine, and in risk, you have an increase in serum creatinine about 1.5 to about 2 times the baseline, and urine output of less than 0.5 mils per kg per hour for about 6 hours. In injury, you have an increase in serum creatinine 2 to 3 times the baseline, or urine output of less than 0.5 mils per kg for 12 hours. In failure, you have an increase in serum creatinine greater than 3 times the baseline, and urine output of less than 0.3 mils per kg per hour for 24 hours, or anuria for 12 hours. And for the previous patient, we had anuria. He had about 60 mils in 12 hours, in 72 hours. In loss, we have loss of kidney function for greater than 4 weeks. And then end stage, we have loss of kidney function for more than 3 months. In the Aki, we have 3 stages. Stage 1, an increase in serum creatinine greater than 0.3 milligrams per deciliter, or about 1.5 to 2 times the baseline, and a urine output of less than 0.5 mils per kg per hour for more than 8 hours. In stage 2, still an increase in serum creatinine, 2 to 3 times the baseline, and 0.5 mils per kg per hour for greater than 12 hours of the urine output. Stage 3, you have serum creatinine increase greater than 3 times the baseline, or you have a serum creatinine value of greater than 4 milligrams per deciliter with an acute increase of more than 0.5 milligrams per deciliter, or a urine output of less than 0.5 mils per kg per hour for 24 hours, or anuria. And for these, we have some conditions that we have to use. So we have to use someone's ideal body weight, not their actual body weight. So like they tell us, always move around with your measuring tape. AKI is classified into pre-renal, renal, and post-renal. And like the previous speaker talked about in the epidemiology, we find that about 70% of people in the ICU may have some form of AKI. And about 5% of these will require maybe renal replacement therapy. So we need to be able to identify and try and prevent some of these complications that we may get from AKI. So we'll talk about some of the causes. This is kind of crowded. It was picked from somewhere, and it really shows us just some of the causes that you can get from the intrarenal, renal, and post-renal causes. The commonest causes in the pre-renal, you have cardiorenal syndrome, you have shock, heart failure, abdominal compartment syndrome, you have kidney medications, some of the medications that could cause you that. Intrarenal, you have so many other causes: sepsis, sickle cell anemia, microangiopathies, you have cellular rejections, you have medication still. And then in the post-renal, you find that most of them are just obstructive. You have either obstruction of the ureters, and oftentimes it has, for one to get an AKI, it usually has to be bilateral. And usually if it's unilateral, you may not find that the patient will get into full-blown AKI. This is another table to show us the commonest causes of AKI, especially in the critical care setting. The commonest causes we find are sepsis, those following major surgery, hypovolemia, low cardiac output states, and nephrotoxic agents. And some of these may be iatrogenic because of the meds that we give the patients. Other common causes can be increased intra-abdominal pressure, cardiopulmonary bypass. For those that are in UHI, you tend to find some of the complications of that prolonged bypass time, trauma, and then rhabdomyolysis. In the pre-renal, We have, usually it's primarily due to a reduced blood flow to the kidneys, like we see in hypovolemia or low output heart failure. It usually accounts for about 30 to 40% of all cases. And it's majorly due to a decreased blood flow to the kidneys. It can be also because of altered intraglomerular hemodynamics, an activation of the RAS that may give us sympathetic stimulation of the RAS system that gives us, that leads to water retention, or you can have renal ischemia still coming in from a reduced blood flow to the kidneys. And for most of these cases, for the prerenal cases, you tend to find that they are a lot more responsive to interventions that increase systemic blood flow, like volume resuscitation. However, if these low output states are very severe and go on for a prolonged period of time, you find that the recovery response may be lost if the low output states are very severe and go on for a prolonged period of time. In the renal and intrinsic, the principal damage is within the kidneys, and it can also be viewed on microscopy. It usually accounts for about 50% of AKI cases. And commonly we have acute tubular necrosis, which is oftentimes secondary from a prerenal injury that has gone on. You find that you have a combination of triggers that gives you the mechanism of injury. You have necrotic tubular cells that form casts and obstruct the lumen, and these activate immune cells within the kidneys. And these activated immune cells or phagocytes also activate a neuroinflammation that continues to cause damage because of the what's it called? Because of the factors that they do produce. We also tend to see a lot of renal or intrinsic AKI from drugs, and some of the mechanisms that the drugs do produce some of this injury could be due to direct nephrotoxicity or immune mediated. Maybe someone was allergic to some of the medication that were given. And then we also have drugs that may reduce your glomerular filtration rates. And then also some of the drugs we give may distort the homeostasis that is achieved by the kidneys. So that's how some of the damage can be brought on by the drugs. These are some of the common drugs that are implicated in AKI. Most frequently, you have NSAIDs to give us an intrarenal hemodynamics. You have some ACE inhibitors, ARBs, cyclosporine, and then you have other drugs that may give you some osmotic nephropathy, like hydroxyethyl starches, mannitol, or immunoglobulins. You have drugs that will cause you renotubular injuries, like aminoglycosides, amphotericin B, antiretrovirals, cisplatin, and some that will give you some interstitial nephritis. And for those, most common are the antimicrobials, the penicillins, cephalosporins, sulfonamides, vancomycin, macrolides, tetracyclines, and rifampin. And then the other drugs like H2 blockers, some NSAIDs, some PPIs, and some anticonvulsants. The post-renal AKI is often obstructive, and it's rare in the ICU because for most of the patients that are in the ICU, they are usually having a Foley catheter in situ, unless otherwise. But for most of the time, it's a very rare complication. It's responsible for about 10% of the cases. And like I said earlier, you need to have bilateral obstruction for someone to actually get full-blown AKI. In my talk, as Dr. Nampina, please, you're sharing your video. In my talk, I was told to talk about the Lasix challenge and a furosemide stress test. So oftentimes you see people trying to challenge the kidneys with a Lasix challenge. But however, this does not improve renal function, and neither does it convert an oliguric AKI into a non-oliguric AKI. Lasix has been found to be better, used in a recovery phase of AKI so that you can prevent fluid accumulation. And for the furosemide stress test, it's a test to try and see progression of either Aki stage 1 or 2 into Aki stage 3 or worsening AKI that may require renal replacement therapy. So for this, they usually give 1 milligram per kg for a patient that has been loop diuretic naive. And then for those that have been on loop diuretics, you give them 1.5 milligrams per kg, and then you monitor your urine output within 2 hours. You want to assess the progression towards advanced AKI, like in Aki 3, or maybe someone has been in Aki 1, and you want to see you want to assess their, it gives you an, English. Okay, it gives you an idea of how rapidly this person will progress to Aki 3. So someone passes the FST test if they produce more than 200 mils of urine, and it usually indicates intact tubular function. This is because Lasix is not filtered in the tubules, and it's a good measure of tubular function. And if it's less than 200 mils, someone fails the FST, and it usually indicates an ongoing renal dysfunction, which may progress further and may require renal replacement therapy. In the diagnosis of AKI, you have to be meticulous in your history and in your examination. In the history, like we said, some of the commonest causes of AKI are sepsis. So you want to look out for your possible causes of sepsis or features of sepsis. Or possible causes of hypovolemia. Was this patient vomiting? Were they having any GI bleeding? Were they having GI losses, maybe through vomiting, diarrhea, and all? You also need to know the drugs that they've been on and how long they've been on the drugs. And also you need to know for how long the urine output has reduced and the rate of reduction of the urine output. Then for most of the cases that you find that the patients here will be on some form of herbal remedy. So you also need to elicit that. I think in one of the, I think there was a study done in Chirudu, and it showed most of the people that came in with renal failure, most of them were on some form of herbal remedies for some kind of form of illness. You also need to track the urine output, and if you found a patient that is not having a urinary catheter, please insert one right away so that you can track them. You can track their urine output. You can do some investigations in your chemistry. You would like to know their creatinine, their urea, and other markers. In the CBC also, you as baseline. Then in the urine, you would like to do a urinalysis. You can also do a 24-hour urine assessment. And we'll talk about some of the tests that can be seen from some of the results, or some of the results that kind of lead us to a conclusion of either pre-renal, renal in some of these. You can do a renal ultrasound for some people that could be having chronic kidney disease, and a renal biopsy, especially if you're suspecting intrinsic or renal AKI. You can also do some kidney markers like cystatin C, KIM1 and NGAL, and these are markers to just show us kidney function, and most of them are more of research oriented. However, a faculty available and the nephrologist around that is yet to speak, maybe we'll throw some light on which markers they prefer to use and which markers are more specific or sensitive. So in the urinary measurements for evaluation of an AKI, you can do a spot urine sodium. And for pre-renal disorder, you tend to find that you'll have a reduced urine sodium of less than 20. And in the renal disorder, you'll have it elevated greater than 40. However, this is not so conclusive, because in some pre-renal causes may have an increased spot urine sodium, especially if the patient has been on a diuretic or they were having some earlier kidney disease or renal insufficiency. You can do a fractional excretion of sodium, and you tend to see less than 1% for pre-renal disorder and greater than 2% for a renal disorder. And for this, still, it's also not very conclusive, because you can find that an increase in you can find a false increase in the fractional excretion of sodium in patients that have been on diuretics, or someone that has been having chronic renal insufficiency, or you can find a false decrease in patients that have been having renal failure or AKI due to sepsis, due to dyes or myoglobinuria. And same thing that goes for the fractional excretion of urea. And for this, you cannot, it's hard to distinguish between renal and pre-renal. This we talked about earlier, it's a diagnostic criteria. And like we said, we use the ideal body weight for these patients. Sometimes we never have a baseline for some of the patients. And we just try and trend. Usually if you find it's increased, you try and start the trend yourself while you also monitor. So this is a schematic just to try and show us the flow of the kidneys from severity of the AKI, the injury, and the recovery phase. So as you see in mild AKI, you find that we had healthy nephrons, numerous in number, and in the recovery process, most of them are still intact. So in the long-term outcome, you find that there's full recovery of nephron function and structure. You have a single nephron GFR, which is normal, and an increased risk of of I've forgotten that in full. I'll go back to that later. So in moderate AKI, you find that still your nephrons are reduced much more, your injured nephrons are much more reduced than in the mild AKI. And at the recovery phase, there's a marked reduction. However, you still have some regenerative nephrons that are still available. So you have some GFR partially recovered, you have some nephrons lost, you have some regeneration, and you have an increased risk of CKD, cardiovascular disease, pardon? Cardiovascular disease and possible kidney cancer. Then in the severe AKI, most of the nephrons are really injured. And at the end of your recovery process, you have very few nephrons that are left. So you have a markedly large reduction in total GFR. You have many nephrons that are lost. You have no or few nephrons that have regenerated. You have an increased risk of CKD, kidney cancer, cardiovascular disease, and also single nephron GFR is greatly increased. And these were my references, and that is the end of the talk. Thank you so much. Back to you, Dr. Erasmus.
Thank you very much, Dr. Namwaya. Quite concise. I hope this kind of helps us build on the previous presentations. We started with the physiology of acute kidney injury. Then we proceeded to epidemiology and a clinical case with its outcomes and outcomes of AKI. We've seen the pathophysiology and diagnosis here. So soon we shall be taking questions, but first I would like to pass us to Dr. Cornelius to run us through another poll. Then after which we shall come back to questions. So kindly post your questions on the chat as we proceed. Thank you.
I would think if we give excessive chloride-rich fluids like normal saline, we tend to cause hyperchloremic metabolic acidosis, thereby, I think, predisposing someone to a risk of an AKI. But Dr. Erasmus can expound on this.
Right, Namwaya. So yeah, definitely the question here is about how much fluid you're giving the patient, what goal you're trying to target, and what content you're using for giving fluids, really, which solution. But it comes down to the simple salvo here, that the poison is in the dose. So everything that we do in excess ends up being a problem to a patient. So excess fluid unnecessarily will become a poison to the patient. So let's say the patient, in most cases, you have patients who are fully feeding. I mean, they're on goal feeds, they're drinking enough, they are peeing enough, but they're also having a drip of IV normal saline or Renal started running in the background. So all this fluid has to go out somewhere, as we hope that the patient is able to pee it out, or the cardiovascular system is going to handle it very well. But remember, this critically ill patient have multi-organ dysfunction, and frequently this gets overwhelmed, and the patient ends up with a splanchnic congestion, splanchnic venous congestion, or heart dysfunction, and then you get into a situation of venous congestion and eventually AKI. Of course, also the content, if you're using hyperchloremic fluids, like Dr. Namwaya tried to say, patient can get into hyperchloremia, which is associated with AKI in one way by poisoning the renal tubule somehow, and the renal perfusion gets messed up. But overall, the biggest issue is patients are better kept euvolemic or dry. Basically, the patient's thirst center is the best tool to guide us on how much fluid the patient needs. So once the patient's awake, follows in commands and can drink, please kindly let them drink, let them eat. But otherwise, giving them excess fluids can cause a lot of dysfunction to them. There are a lot more intricate molecular mechanisms to dysfunction of the vascular system. The endothelial glycocalyx, for example, among others, can get disrupted, and that will lead you to a lot of vasculitis, a lot of endothelial failure, and venous and visceral congestion, which is AKI. Yeah, let's see if there are other questions. Okay, Dr. Claire already gave an answer there about interstitial edema. Dr. Christine was also giving a response. Increase in renal venous pressure impairs or reduces renal perfusion pressure, as happens in heart failure or reduced ejection fraction. Yes, I hope the fluid excitement is going down now. Whoever is excited about fluids, please calm down. Dr. Cornelia says, perhaps to break down the question, Peter asks, does excess fluid cause AKI? What type of fluid increases the risk of AKI? Yeah, so basically, excess of anything, as you mentioned, is going to be a risk factor for acute kidney injury, as it is a risk factor for any other form of organ dysfunction. And remember, there's increased organ crosstalk. When you mess up one organ, there's going to be a mess up in the others as well. But particularly if you're going to use hyperchloremic fluids or balanced solutions, there's been evidence that they kind of worsen the chloremic loads in patients, especially normal saline. And as such, you may end up with endothelial dysfunction. Yes, Dr. Cornelia says, perhaps we can all go read up how excessive intravascular fluid affects the glycocalyx and the endothelium. Yes, all right. So I think that is it for the questions that we have. So, Doctor, we've all done the poll, and some of those questions in the poll were relevant to the questions the topics we've already covered. The next speaker is a guest from our sister specialty nephrology, Dr. Robert Kalesubula, who's a senior lecturer in the Department of Physiology and a nephrologist at Makerere University, and does private practice around town as well. He's going to take us through the novel biomarkers or biomarkers in AKI, and perhaps so he will give us a bit more guidance on how to actually diagnose AKI in ICU. But perhaps before he comes on, I'm just going to ask a random question to some of our colleagues who do practice in ICU. Dr. Huntington Semanda, our colleague from Kenya, would you care just to share with us how you guys diagnose AKI in a patient who is in ICU in your unit? What are your considerations? Dr. Huntington Semanda. Perhaps we can just proceed, Dr. Kalesubula. So kindly welcome Dr. Kalesubula. He's our colleague who will be taking us through kidney biomarkers and the search for a kidney troponin. We're trying to see if we can diagnose kidney injury earlier as well, and whether there is a marker now or in the future that will be able to identify AKI long before it becomes clinically apparent and clinically complicated. Thank you so much, Dr. Kalesubula, for joining us. The floor is yours.
So thank you very much for inviting me. Of course, as Erasmus would, he gave me quite a hard topic. So I had to do some reading around. Thank you for the introduction. I think the discussions have been great. My thing was not moving. So I'm going to talk about little bit about new classification of AKI, and then the current methods of diagnosing, and then delve into some markers. Really, the bottom line is these markers are great, but perhaps they are not yet ready for prime time. The previous speakers have spoken about this, so I think we are currently using creatinine and the level of urine output to define acute kidney injury. But the new paradigm, which is relative there, this is a paper that is in press. Maybe what I should talk about is that over time, when we talk about acute kidney injury, we talk about this in the first 7 days. Of course, as you said, this depends on whether it's community acquired or in hospital, but usually 0 to 7 days. What we did not have was what happens in between the 7 and the 90 days. Because after 90 days, you go into what we call chronic kidney disease. But now we have a new term called acute kidney disease. So if the injury occurs between 70 and 90 days, that is what now we refer to acute kidney disease. And now studies are being undertaken to study that as well. Of course, this I borrowed from the paper we are going to publish, but that's the point I wanted to talk about. At any point, the kidney can reverse into recovery, or it could progress into CKD, and of course, subsequently mortality. So mainly when we are looking at the kidney function or the kidney damage, we look at the function of the kidney, which we mainly measure through the glomerular filtration rate, or if we are looking at the structure of the kidney, we then look at what happens to the glomerulus and what happens to the tubules. So if you are looking at the glomerulus, you know the markers are going to be dysmorphic red blood cells and everything like that. If you are looking at the tubules, you look at the urine and you see some scars and all those other changes. But also microalbuminuria is a major marker of then the glomerular basement membrane. So today we are going to concentrate a bit more on the kidney function. So the gold standard for measuring kidney function, therefore, would be in urine, but this is not readily available. So we mainly use creatinine, which is an endogenous product of muscle breakdown, and it's usually produced at a constant rate, and it's filtered, but a bit of it is secreted. Urea can be used, but very rarely because of what I'm going to show moving forward. So urea usually increases when you have reduced GFR, volume depletion. Most of the things have been shared, but of course, it decreases when you have volume expansion or liver injury. So we can use urea in the diagnosis of AKI usually in one incidence where you have the urea creatinine ratio. Before you use diuretics in the early stages of kidney injury, if the urea creatinine ratio is above 20 times, then you are looking at perhaps contracted extravascular volume. So it can tell you that you probably have pre-renal. I know the previous speakers have spoken about this, and this is because when you have acute kidney injury and you have volume depletion, the reabsorption of urea is increased by the proximal tubule. So the urea is much more compared to the creatinine, which would appear concentrated. Creatinine, as you know, comes from dietary muscles, it's freely filtered, and of course, it can be affected by some drugs, as you know, like trimethoprim, amongst others. It increases with age. It increases with age, its level. Of course, when the GFR reduces, the creatinine also goes up. The problem with creatinine is that unlike the troponin, which is the gold standard according to Erasmus really in this talk, is that when you poke the heart, a small touch to the heart will raise the troponins, be it an inflammation, be it an injury, whatever form of injury goes to the myocardium, the troponins go up. Depending on whatever injury it is, they can be typed. But here, the kidney, in order for the creatinine to go up, you need to destroy about 1 million nephrons, which is basically half of your kidneys. in order for the creatinine to go up. So really, it is a slow marker of kidney injury besides these effects. These are the normal, but of course it's elevated also in people with large muscle mass and those with decreased tubular secretion. There is an inverse relationship between creatinine and the level of kidney function. When the level of creatinine goes up slightly, for instance, a rise of creatinine from 1 to 1.5, the kidney function will definitely decrease very much. But as the creatinine goes higher, the relative decline in kidney function is going to be little. This relationship should always be kept in mind. So basically what I'm saying is that both urea and creatinine, which we commonly use, have a lot of evidence, but they are poor markers. Therefore, we need to think about other ways of finding out how we can tell kidney injury much earlier. As the person who spoke on pathophysiology told us, here we are looking at the tubular, which is normal. Once we get this injury, which is usually ischemia or reperfusion injury or direct nephrotoxicity, then we injure these cells. Once these cells are injured, as I showed you in the AKI, AKD, CKD model, depending on what happens, if you keep the injury around, if it's direct toxicity, if it's inflammation, you don't remove it, then you get persistent injury, which ultimately leads to acute tubular necrosis and tissue fibrosis, and then you lose functioning nephrons, which now leads to kidney injury. But if you remove the injury, then you are able to recover. And I think the previous speaker showed some good models of this. And this is basically where we are at. You have a normal kidney, it is at increased risk. This is where we want to be able to pick up people when there is a ischemia or there is toxicity. And then these markers, which we are going to be talking about in the next few minutes, rise up earlier. And we want to be able to detect kidney injury much earlier. You'd use the markers. Later on, of course, our usual injuries come in and you are able to detect it with creatinine and serum, but this is much later. So I think what we want to talk about is what can we do between normal and to be able to detect early damage. This is the paradigm which we are going to be talking about. We look at healthy individuals, but these healthy individuals, acute kidney injury is a function of your genetic susceptibility and of course, although your environment. So in precision medicine, we look at the person as an individual and be able to pinpoint. This is where we want to go. But currently we are here at functional markers where we detect kidney damage quite late. We want to shift a little bit here where we can do molecular profiling and be able to pick up people earlier. So what would then a perfect biomarker look like? The perfect biomarker ideally is probably not going to be a single marker, but it's going to be a combination that can discriminate between stages of kidney injury and also be able to tell you where the injury is coming from. Is it from the glomerulus? Is it from the tubular? Is it vesicular? Or is it from the interstitial? And then it should also be able to differentiate for you in case you are treating your patient when they are recovering. Does the mark get better or does it get worse? That would be the perfect mark you would be looking for. And because of course, Erasmus told me to talk about this. One of the good markers of injury, as you know, is the troponin. For them, when they were studying it, they would use a surrogate of 25% reduction in left ventricular function. And so when you are interpreting these tests, you look at sensitivity and the specificity, which is going to tell you what is happening to the heart. And are you able to tell exactly what is happening to the heart? Are you able to take in the people who are injured? And are you also able to rule out the false positives? And of course, for interpretation, you want to use your log curve and you want to be able to have as much sensitivity and specificity as possible. So for acute kidney injury, unfortunately, we don't have a good gold standard. We use a rise in creatinine of 0.5 milligrams per deciliter, And unfortunately, most of the studies have used this gold standard of serum creatinine, which actually, as I've told you, is actually affected. So this, as we review the science that's available, you should put it into context. So an ideal marker should be non-invasive. You should be able to measure it. It should be available at like in blood or urine. It should have high sensitivity and high specificity, and should be able to tell you when the kidney function changes. And of course, should be biologically plausible. Some of the biomarkers that are currently available are these ones: the neutrophil gelatinase-associated lipocalin, interleukin 18, and the kidney injury molecule 1, liver fatty acid binding protein. So the major ones that have been studied are actually the NGAL, the interleukin 18, and actually the kidney injury molecule, as well as the liver type fatty acid binding protein. Many of these are secreted from the different parts of the kidney. So to some extent, they are able to tell you where the injury is occurring. And then some are able to tell you what is the mechanism of injury. Like if you have nephrotoxic drugs like nephrotoxins, like amphotericin B, cisplatin, these actually are able to pick up the site and cause of injury, like the NAG, glutathione transferase, but these have not been studied very well, except maybe the NAG and the kidney injury molecule, as I'll be sharing briefly. Of course, in order for you to decide whether a marker is going to be useful, a clinician would want to know, can it help me to diagnose the patient early enough? And if it helps me to diagnose the patient, if I treat the patient and it gets better, does the marker improve, as I shared earlier? So these are some of the markers that have been studied in clinical trials. I'm not going to go into details about them, but each of the markers has a specific site where it can define the injury. For instance, if you're looking at glomerular function, cystatin C, NGAL, retinol binding protein, and epsidin can be markers there. If you are looking at tubular function, cystatin C, NGAL, and retinol binding protein, which actually is produced by the liver. Then you also have some markers of inflammation, and then you have markers of tubular damage, because mainly you want to be able, most of the markers have been studied in the urine because it is easily available and actually non-invasive. So these are some of the markers that have been studied there. And so, but most of these markers, they are usually non-specific, and they are usually studied in specific condition. Particularly the cardiologists do a good job in studying these markers, because when there are people on pumps, they can study normal kidney, and then they see when there's perfusion, reperfusion injury. So in a recent meta-analysis, they actually showed that NGAL, interleukin 18, and cystatin C are one of the key markers, because they are able to predict the need for renal replacement therapy in AKI, and they are also able to predict mortality. But some people have also combined the markers to see and made a kit to see whether they can be able to predict outcomes in this. So as I talked to you about sensitivity and specificity, you can see that if you look at the NGAL, the sensitivity is good, but the specificity is quite low. If you look at the TIMB, again, most of these sensitivities, you can see that they are quite low, as well as the specificities. So these markers are sometimes able to pick up the injury, but they are not sensitive. Many different causes of disease can actually stimulate their rise. So in order for you to be able to tell that the mark is good, it should be specific and very sensitive. So what some people have done is to combine some of these tests. There is a kit that has been developed and is being tried in clinical practice now. It is the NephroCheck, and this one has been shown to detect acute kidney injury in patients with the cardiovascular compromise who are admitted in ICU. And this clinical performance was actually superior to individual markers like KIM1 and NGAL. and it was less affected by comorbidities. So this is what is currently available, but is still being used for clinical trials rather than clinical practice. Of course, these markers are also quite expensive. As you know, the creatinine test might be around $2 to $3, or if you are in private practice, perhaps $5. But these tests are all much more expensive and not readily available. So some of the recommendations for use of these biomarkers, according to some guidelines that have been produced by the consensus statement, is really to help you fit in the paradigm, to be able to tell you which patients are at increased risk, and then also define for you which patients are likely to progress to chronic kidney disease or even cardiovascular risk and death. So the recommendation is that a combination of some of these markers can be used, but the patient should be individualized in context. Clearly, the guidelines don't tell you use this mark, use this, except the NephroCheck, which currently has some literature. So really, in brief, what I'm trying to say is that these biomarkers are good. They are not yet available for routine use in patient care. A good mark is likely to be a combination of these rather than one. We really need to conduct more research, and the cost needs to come down in order for us to be able to use these markers. I think that's what I had. I would be happy to take on some questions.
Thank you very much, Tubular, for that quite concise and succinct talk. Team, so we have it there, the different biomarkers to use for acute kidney injury. And I guess the big message is that we are not there yet. What's clinical available is relatively less sensitive or specific, and what is ideal is super expensive and still being used in research, and probably will not answer our question either. So, like Dr. Scalesula said, it's more of a combination. I'd like to welcome questions to Dr. Scalesula's talk, and Dr. Scalesula is right here with us. He will be answering these questions. Could you just...
can we have Dr. Scalesula maybe respond to some of the poll questions that were posed before his talk? So like this one, glomerular filtration rate is a sensitive tool in assessment of AKI in critically ill patients. As the other people prepare their questions, perhaps Dr. Scalesula can respond to this.
I think the glomerular filtration rate, is a sensitive tool in assessing acute kidney injury in critically ill patient. I don't think glomerular filtration rate is a very sensitive tool in assessing AKI, for the reasons I've shown you. Glomerular filtration rate largely depends on the clearance of creatinine, which is already a bad mark and is affected by other things. So if you are going to do, if you are going to get a good marker, then you are probably going to be talking about creatinine clearance itself. Because in the creatinine clearance, you are able to correct for the serum concentration as well as the components in the urine. Whereas if you just do the glomerular filtration rate, which is usually estimated, you are not going to be able to get the true function.
Okay, thank you very much, Dr. Scalesula. Then the next question was, in AKI, good urine output is always a clinical sign for improving renal function. Your comment?
Yeah, actually add a statement to that. And I think that's a very big misnomer. We've had some challenges. At one point, I've come to my colleagues who are in ICU, and I say, let us dialyze this patient because the pH is 6.9 and the creatinine is 800. It is jumping up to 1,000. And the people say that, oh, but the patient is producing urine. So the production of urine largely depends on the status of the tubules. Sometimes if you have the tubules, as you saw in the mechanism of injury, if some of the tubules are not so much damaged, they are actually able, like when you are, in fact, the person who talked about the fusemide stress test, if you want to know whether the person is going to respond to fluid therapy or anything, you use that fusemide stress test, but it basically tells you whether the tubules are still working or not. It does not tell you about the interstitium, it does not tell you about so you can have non-oliguric renal failure and the production of urine is not actually always a marker that the kidney is doing well. If initially the patient has been anuric, beginning to produce urine is actually a phase which usually occurs within 7 to 14 days, and it shows some recovery of the kidney when you are going into the polyuric phase. But if a person continues to produce urine, it would just mean sometimes they have just interstitial injury and they are just not able to absorb that small urine that passes there. Remember that every 24 hours, the kidney filters about 180, clears about 180 mils of blood. So in that 180 mils of blood, in order for you to produce those 2 liters, 180 have to be cleared and the rest to be absorbed. So if the kidney is damaged, it can actually spill one of those 180. It doesn't mean that it is necessarily doing a good job.
Thank you very much, Dr. Karesu. I think that was excellently put. Let's not be fooled by very good urine output. It's not always a good marker. Thank you, Dr. Karesu.
Dr. Elias, I would also probably like to ask Dr. Karesu to respond to the question by Dr. Fred regarding referral of patients with AKI. At what point would he prefer that these patients are referred to a tertiary facility capable of renal replacement therapy or specialist support in the AKI upcountry?
I think the key note here is not a single figure, but usually the whole context of the patient. You know, as critical care specialists, you are always taking care of very sick patients. So you have to look at the cause of injury of the kidney, but more importantly, the level of change. That's why actually we don't use GFR. We don't use estimated glomerular filtration rates when we are, of course, it can help you, give you an idea, but the creatinine is not in steady state. It is changing all the time. So as I've shown you, if a person's creatinine rises from 0.4, let's just use the creatinine, for instance, 0.4, the normal range is usually 0.7 to 1.2, and it goes to 1.4. That person's creatinine level of rise, we know that a rise in creatinine of 0.3 milligrams per deciliter is actually associated with increased mortality. So the level of rise of the creatinine, if you are able to measure it anyway, should be able to give you an indicator. If today you see the creatinine is 1, the next day is 2. No, unless there is very clear, certainly the patient is very dehydrated, you have a clear explanation to it. That's the person you are likely to refer very fast. But if the rise is slow, then that person might probably stay around. Unfortunately, the question you are asking me does not have very true ready answers because of the nature of the biomarkers we use, but also because we don't have good treatment for acute kidney injury. And that's why I think Dr. Erasmus asked me to give this call. Your best shot is always going to be around prevention. Prevention number 1, prevention 2, prevention 3. If your patient has gone to theater, you know that they have lost 5 to, okay, maybe 5, they will die. They have lost about 500 mils of blood. You show the surgery was difficult, it was prolonged. This patient is likely to develop AKI. So don't wait until the urine output goes low to replace the fluid. You are just going to be, you have to just suspect this and begin to protect it. This is a person, unless they are really just sensitive to amikacin, you would not want to give them amikacin. So the time of referral would actually depend on the level of rise of this patient, as well the comorbidities of your patient. I know I'm not giving a direct answer, but the truth is there is no a direct answer to this. Thank you.
Thank you so much, Dr. Kayasubla. I guess also the bigger message to remember is that AKI is really a syndrome, just like we look at AIDS, just like you look at ARDS, sepsis. You know, these are it's basically a syndrome of of issues going on with the kidney following some sort of insults to it. And as such, there's no one thing that's going to give you an answer. And like we say, the question is the patient getting AKI as an isolated organ disease, or are they getting AKI as part of multi-organ dysfunction? And if it's multi-organ dysfunction, then there are going to be a lot more pointers for you to potentially refer this patient to a higher level center earlier than just focusing on the kidney alone. The kidney tends to be a victim, a bystander being flogged here by some multi-system disease. Yeah, thank you so much for that presentation, Dr. Kayasubla. Would like to move on to the next stage, but before we do that, Dr. Cornelia is going to run a poll. We're going to run out some poll questions before we do a home run. So, all right. So, Dr. Cornelia, over to you.
Right, here's the first poll question, which I'll have about 40 seconds to respond. And this one is about, in AKI-associated hyperkalemia, which of the following fluids is safe for volume expansion? Okay, I'll end the poll now, and then I'll share the results. So slight edge, ringers, 50% of the audience chose ringers lactate. Let's go to the next. Here is the next poll. Calcium chloride should be administered in all cases of hyperkalemia, regardless of the cause. Okay, 40 seconds are up. I'll end the poll now. And these are the results. Just a slight edge, 51% said false. So hopefully we shall get the answer to that as we go through the next presentations. And then the next poll. Yeah, it is. In case of hyperkalemic induced bradycardia in AKI, which of the following interventions is immediate life-saving? Okay, 40 seconds are up, so I'll end the poll here. And these are the results. Over 60% selected IV calcium chloride. Okay, and then second last poll, it will be about one of the talks coming up. So in which of the following AKI patients would you recommend adding dialysis? Okay, 40 seconds are up. These are the results. So a majority, 53% selected acute pulmonary edema, then anuria, and then very high serum creatinine. The final poll. There it is. What is the first choice renal replacement therapy modality in AKI patients in shock? Okay, I'll be ending the poll in the next 4 seconds. So in the poll now. So in first choice, 53% have selected continuous renal replacement therapy, followed by SLED, followed by ISD, and then peritoneal dialysis. All right, thank you. Over to you, Dr. Rasmus.
All right, Tim, thank you very much again for your participation in the polls, and Dr. Cornelius for guiding us through that. I see Dr. Fred decided to abstain from this conversation. Okay, Ernesto, leave Daddy. All right, sorry for the interruption. We over the next 30 minutes, I know we're going over our usual time again. Over the next 30 minutes or so, I would like us to have a rapid fire now. Basically, it's going to be back-to-back presentations on management of AKI. So we're hitting the home run here. So kindly pay close attention as the talks come through. ask some of the questions you have. So next presenter is Dr. Peter Waswa Umulongo. He is an anesthesiologist and a fellow in the in our scale program. He will be taking us through the medical management of acute kidney injury. So kindly take over the floor, Doctor. Right after him, we shall have Dr. Namata. Dr. Christina Mata is an anesthesiologist intensivist, just freshly out of a fellowship, back home in UBC, and she will be taking us through the through artificial management, I guess, or non-medical management, which is really medical. She'll be taking us through renal replacement therapies, and that to hopefully fill in the gaps for what we have seen in the questions. So, Dr. Peter, please share your slides and start presenting to us. Thank you. Dr. Peter Mulongo, kindly share your slides and please start presenting to us. And I see you're having some technological issues. Dr. John Yagu Manawe, you're thinking, you're thinking right. Would like to highlight your name and look out for you, in the subsequent years as you plan to apply to us. We would love to take you through and bring you out as a safe doctor when a doctor is really needed. And that means you are welcome to participate to train in any of the emergency areas where doctors are really needed. So talk about emergency medicine, anesthesia, critical care, so yeah, sure. I think Dr.
Rasmus.
Yes, Dr. Cornelius.
Maybe as Waswa sets up, I will probably just request you to give some comments on this particular poll. I hope by the end, this is regarding in oliguric AKI, the following is true. Please make some comments on that as we wait for Dr. Peter Waswa to share his screen.
All right, thank you so much. In a patient who's not producing urine, I think for the part of this was answered by Dr. Sophia's talk. You cannot really convert AKI from non-oliguric to oliguric by using diuretics. That's basically captivity of euboxia. You're basically excited to see urine flowing, but the truth is that you're not really affecting or altering organ function. If anything, you could be putting this patient in a mess by disturbing the fluid dynamics in them by giving them diuretic, if they're not really responding well. At the same time, the diuretics have their own tissue, they have own side effects that the patient could end up nursing, things like autotoxicity, neurotoxicity for loop diuretics, for example. So probably not something anyone wants to do. Dopamine really was kind of misleading before. We saw some patients developing increased urine output after receiving dopamine, and so people were thinking that was protective of urine of kidneys, but in the end, actually, what we're having is a slightly altered hemodynamic profile at the splanchnic and renal vasculature, with some technically what I could call loosely a diuretic effect, but in the sense it did not really improve renal function. Then balance that against the complications that you can get from use of dopamine, it definitely becomes something you don't want to use, especially for this purpose. There was also the fear that increased use of increased protein intake would increase ammonia, which increases the urea, and therefore patients will end up getting sick. So the issue here is really about the chicken and the egg. The problem is the kidney cannot is having its own intrinsic problems. So protein is going to be essential for healing, immunity, among other things, and as such should not be restricted in this patient. So the answer to this question is none of the above is actually correct. Dr. Cornelius.
Okay, over to you, Peter.
All right. I think Dr. Peter is still having a bit of trouble with technology. Dr. Cornelius, Peter, are you ready to present?
Yes. We are trying to share. We're trying to share.
We are sharing the screen.
All right. So I guess
we can see the screen. We can see the screen, guys.
I think it's called from the poll question that should ever restrict in patients who have got AKI. They need it. Definitely depends on the stage of illness as well, when they might be in. And don't rush to using furosemide unless you're treating electrolyte abnormalities or fluid overload. And dopamine is really just taking a waste of your time, unless it's the only vasopressor you happen to addressing hypotension. So over to Dr. Peter. Dr. Peter, on your side, there's a lot of feedback. So many people are speaking. You take over, Dr. Peter.
Okay, a good evening to you all. Peter Wasa is my name. I'm going to be presenting medical management of AKI in ICU, and then at the end, I'll review the START AKI trial. The previous presentations, what our take home is management of AKI is basically supportive, and actually there is no definitive intervention for it. But as you're managing these patients, you're always having some goals in mind. The major goals you're going to be having in mind is you want to maintain the volume hemostasis of your patient, and then to correct the biochemical abnormalities that accompany AKI, which we are going to talk about. So anything that you're managing, you want to understand what has caused the AKI. From the previous presentations, the different pathophysiologies of AKI, and then what can actually predispose your patient to AKI. So when you receive a patient, that's the first question you want to answer. What has been the cause for AKI in your patient? Once you identify it, management becomes easy. And then you want to review on the things that your patient is taking. Most likely these are medications. And then you want to stop all medications that are most likely going to worsen your renal function. Then there are some other medications that you'd want to renal depending on the patient and the medications and the stage of AKI. Maybe what's important to note is from the presentation of Dr. Kalyasubula, we're able to know that actually creatinine is not as superior as we expect it to be, yet we actually use it in estimating GFR. That most actually based on to classify their patient. However, when someone progresses to end stages of AKI, the rise in creatinine may not be as more beneficial to you as you might expect. One of the commonest biochemical abnormalities in patients with acute kidney injury is hyperkalemia. And it's a fatal thing when it's not identified early. So it's good for us to, in all our patients that present with the AKI, to have goals of management of their hyperkalemia. So for purposes of time, I'm not able to give you the details of how you manage a patient with hyperk for the given levels, the given changes in the ECG, but was able to put in for you goals for management. You don't want to reduce on their intake for potassium. You don't exchange potassium across the diagotomy. Now, when it comes to potassium binding resins, they have limitations. For example, in our setting, the commonest we have is Kayexalate, but actually Kayexalate has not been found to be beneficial in patients that have hyperkalemia in the acute settings. Instead, there are two other potassium binding resins that have been found to be of some value. But the one that has been found to be actually overused is sodium zirconium cyclosilicate, abbreviated as ZS9. So it plays a role in the acute management of a patient with hyperkalemia. Then we'd want to increase on the shifts of potassium from the blood into the cells using things like insulin dextrose and then salbutamol. The dosages, of course, are going to differ when it comes to patients that are not having hyperkalemia. And then instituting dialysis would be the end stage when you have actually failed to do medical management. But Dr. Christina Mata is going to give us the details about dialysis. So I've talked about the potassium binders, and then I quoted for you something to use. Then the other thing, when managing a patient with acute kidney injury, you'd want to optimize the hemodynamics. What are you trying to mean? Some of these patients are going to come in when they are having either very high BPs, especially in patients that come with the intrinsic renal injury, or they may be hypovolemic. So you want to maintain perfusion to your kidney, being guided by the mean arterial pressure. When it comes to euvolemia, so patients are going to come, they could be hypervolemic, normovolemic, or hypovolemic. So the approach you're going to use is going to depend on the state with which the patient presents to you. Patients that are going to come in when they are really hypervolemic, of course, you're going to assess using the clinical examinations and then a few investigations, some of which have been hinted on, like focus, whereby you're going to look for, like patient is breathing spontaneously, you want to look for respirophasic variation or the inferior vena cava, whether it's collapsible. And then in case maybe the patient is on the ventilator, we want to look for your distensibility index. And then you wouldn't want to overhydrate a patient who's having acute kidney injury because they are not able to really excrete this too much that you provide to the patient. And then you wouldn't want to keep a patient who's hypovolemic, dehydrated, because you want to reduce on the instances of acute tubular necrosis, and then you want to improve your renal perfusion. So the goal is to maintain euvolemia. So one of the other biochemical complications expected in patients with acute kidney injury is metabolic acidosis. They actually present with mostly the uremic acidosis. So when you're managing these patients, you want to target a pH of about 7.2. So a pH of 7.2 is approximately equivalent to a bicarb of about 17 milliequivalents per liter. So patients that are going to present when they're really hypovolemic, we do want to resuscitate them with isotonic bicarb. So in our setting, we have isotonic bicarb that comes in about 2 preparations. ampoules of 10 mils, and then ampoules of 25 mils. When you go to other settings, they have ampoules of 15 mils. So the goal is you want to put about 150 mils of hypertonic bicarb, the lid of D5 make isotonic bicarb. So some studies have been quoted, have actually used isotonic bicarb to enable patients survive being dialyzed. And then some patients may present with hyponatremia as one of their complications. So such patients, actually, the common notion in settings that we use actually 3% or 5% sodium chloride. However, you can actually use hypertonic bicarb to correct someone's hyponatremia. And 100 mils of a preparation of 1 equivalent per liter of sodium bicarb can increase your bicarb sorting acidosis, and those increase the serum sodium by about 3 mil equivalents per liter. So patients that have mild acidosis may choose to do the oral route. In case the medical fails, you end up with dialysis. Okay, so what is the role of loop diuretics in the management of AKI? So loop diuretics have been used for some good time to assess tubular function, and then to when they're giving their furosemide stress test, or what we call a Lasix challenge. But on top of that, we also have other important benefits to our patients with acute kidney injury. One, they're going to reduce oxygen consumption of the thick ascending limb of the loop of Henry, which would mean we are going to be protecting it from ischemia, because actually reducing how much it's consuming. And then they also inhibit prostaglandin dehydrogenase, which is a renal vasodilator. So that would mean when they reduce the breakdown of prostaglandin E2, which is a vasodilator, we are going to be improving renal blood flow. The other thing is we are going to maintain now that bullet number 3 about maintain urine flow, which may prevent tubular obstruction. It's a contentious issue. It's not 100% true. And then now, the conversion of oliguric to non-oliguric AKI has a star on it, meaning it is not 100% true that loop diuretics are going to convert for you oliguric to non-oliguric AKI. But in some patients, it may be beneficial. And then because you're promoting the excretion of urine, you're going to reduce the fluid overload of your patient. They also come with some challenges. One, you're going to have a reduction in the effective saturating volume. In other words, they may, if you don't monitor your patient's volume status well, they may end up hypervolemic, which is going to reduce renal blood flow and GFR, which means it's going to end up promoting more AKI. They also acidify the urine. That's why I told that bullet number 3 in the previous slide has some connotations, which may also worsen tubular blockage by forming of casts. And then they've been associated with ototoxicity and electrolyte abnormalities, commonly hyponatremia. What is the role of vasodilators in the management of AKI? Now, for that, studies are contradicting each other. So some studies say low doses of these vasodilators are going to improve renal blood flow, thus improve AKI. Whereas other studies say they've not found any benefit in patients with AKI. So what about HIV and AKI in our setting? In our setting, we have lots of HIV. So this is a study that was done in Mbarara by Davis Kimweri, and then he was assessing the incidence and predictors of acute kidney injury among HIV positive patients that were admitted with sepsis. We analyzed 73 patients. Of those patients, 19.2% got AKI. But the only independent risk factor he found in all these patients was a thrombocytopenia. Now, the discussion was because HIV induces severe immunosuppressive state, what happens is people end up with microangiopathic, microthrombi within their tubules. And then the other issue was in HIV, you're going to have patients with opportunistic infections. You're going to have the causes of AKI are going to be multifactorial. The most likely going to be malnourished, most likely going to be low in the immune response. They may even be low in their volume status. So HIV is really a serious risk factor for AKI in our setting. So these are other things I'm supposed to talk about, but the furosemide stress test has been discussed already. So focus in patients with AKI. So because AKI has so many things that can cause it, when you see a patient with AKI, you're going to do focus to assist you come up with other things that could be contributing to the AKI, and also to know whether the cause is renal or post-renal or pre-renal. So what are the things you're going to be interested in? One, you're going to be interested in knowing the size of the kidneys, search for hydronephrosis, glomerular differentiation, look for any scars. You'd want also to, don't forget to look at the bladder, whether it's full, look at the prostate. And then the other thing, you'd also want to look at the CVS. Is the heart functioning well? Is the IVC filled with volume? Is it, all those things assist you to know the exact cause for AKI in your patient. The other thing I was supposed to talk about was post-tubular necrosis duress. You said it's a common observation that in some patients, when they're recovering from AKI, they go into a polyuric phase. So what happens is when a patient gets tubular necrosis, maybe because of ischemia, some of the MRQ1 nephrons are actually not affected. So as the person is recovering from the ATN, they regenerate, and they undergo 3 phases: the initiation phase, the maintenance, and recovery phase. So what happens is, in the recovery phase, you have MRQ1 nephrons that are receiving a huge load of a solid. So because they can't handle it well, most of it just goes through. So the challenge is, in our setting, like if a patient is in the polyuric phase, patient is losing about 1 liter, let me say 2 liters a day. Someone don't replace all the 2 liters. Yet in actual sense, the best thing would be, the right thing would be, use 2 liters, replace half of that volume, so that you enable the nephrons to keep on sensing the volume, and then they begin in their function. Maybe another thing that I was not able to talk about in my presentation that I think the audience will be treated on their own is cardiorenal syndromes. So the other thing you're going to come across when you're reading is what we call organ dependence, whereby a disease of an organ can lead to dysfunction of another organ. In other words, renal failure can lead to heart failure, and heart failure can lead to renal failure. So that's it about AKI. The other thing I'm supposed to talk about is the START AKI trial. Just a review. So the START AKI trial, START is an acronym for Standard versus Accelerated Initiation of Renal Replacement Therapy in Acute Kidney Injury. So this was a multinational, multi-center study that was done, and these guys were answering. So the objectives were, they wanted to determine whether in critically ill patients with severe AKI, randomization to accelerated initiation of RRT compared to standard initiation led to improved survival, which was measured in terms of mortality, death at day 90. And then recovery of kidney function, which was defined as independence from renal replacement therapy at 90 days. So what was their hypothesis? Their hypothesis was an accelerated strategy for renal replacement therapy would result in a lower risk of death from any cause at 90 days than a standard strategy. So it was random, it was an RCT. They did allocation concealment using a web-based randomization system. And then their calculated sample size was 2,866, but to cater for losses to follow up, it was taken to 3,019. There are some groups that were pre-specified, in others, there's nothing to do about them, and then they obtained informed consent. So it was done in 15 countries. None of these was an African country, and 168 sites. So they began collecting data in 2015 and finished in 2019. So what happened was they had patients that were at the accelerated arm. So what happened was those ones would actually receive dialysis within 12 hours of admission. Then they had a standard arm, which was the control arm. So this standard arm, the clinicians at the site initiate the patient on dialysis within 72 hours, or when the patient developed one of the normal indications for dialysis of a patient with AKI. And what was noted was, at the end of the study, 96.8% of the patients in the accelerated arm had received dialysis. And the mean time for initiating dialysis was 6 hours. And they had the average cumulative balance in that population was about 2.7 liters. Whereas in the standard arm, only 61.8% of the patients were dialyzed. The mean time for initiating dialysis was 33 hours. And the average fluid balance for them positive was about 5.2 liters. So what were the outcomes? So the primary outcome was 90-day mortality. And at the end of the study, when they were analyzing their results, they didn't find any significant difference in terms of 90-day mortality between the two. And then about the secondary outcomes, what happens that dependence on dialysis at 90 days after randomization was 10% in the accelerated arm versus 6% standard arm, with a relative risk of about 1.74. And then they also didn't find any significant difference in all-cause mortality and dependence on dialysis at day 90. Major adverse events were more in the accelerated arm versus the standard arm. And then those are the other events that they were looking at. What was the EGFR at day 90, albumin at day 90, mechanical ventilation free days at day 28, and vasopressor therapy free days through day 28. And actual adverse events were more common in the accelerated arm. The commonest ones were hypotension and hypophosphatemia. But in terms of serious adverse events, they didn't find any significant difference. So what were the strengths of this study? Allocation was concealed. Even at the centers, they did stratify. They used the variable block sizes of 2 and 4. Pragmatic design. The outcomes were actually making sense clinically. And the partners and the funders didn't actually interfere. And then it was done in many ICUs in many countries. The results were analyzed, collected 25% of the data. Another analysis at 75% data collection. Weaknesses, because for the standard strategy, patients would make the decision. Like if they say this patient has been recruited, but the patient needs dialysis emergently, those patients actually be excluded. So the decision of a clinician to make a certain decision is not able to be defined with ease. So what was the conclusion from the study? In critically ill patients with severe AKI, an accelerated strategy for the initiation of ARDA did not result in a lower mortality at 90 days than a standard strategy. And also, early dialysis appeared to increase the risk of dependence on long-term renal replacement therapy, raising the possibility of these patients being at risk of dialysis-induced kidney injury. So that's just a slide giving a brief summary of the whole trial. And then those were my references. Thanks for your attention.
All right, thank you very much. Thank you so much, Dr. Dr. Peter. Like I said before, kindly bring questions coming in. I see questions already in the chat. We shall have Dr. Peter come back to answer these questions. Next is Dr. Namata. Dr. Namata, as I mentioned earlier on, is an anesthesiologist and intensivist, fresh from her fellowship from back home. Those of you know, you know. She will be taking us through renal replacement therapies. So kindly accord her the same audience and keep your questions coming in the chat, and some of them can be asked directly later on. Dr. Namata, kindly upload share your screen. Dr. Peter, please put down your screen so Dr. Namata can share hers.
Hello, everyone. Thank you, Erasmus, for the introduction. Let me just try to. Okay. Are you able to see my slides? Hello?
Yes, we can hear you very clearly, Doctor.
Oh, thanks. All right. So thank you for the humble introduction. I'm Christine, and we're going to talk about renal replacement therapy. So as already determined, the kidneys do a meticulous job, and I found this quote very interesting. Aldous Huxley was an English philosopher in the 1800s, and he said, you know, the kidneys are so beautifully organized. They do their work of regulation with such a miraculous start to find another word, such a positively divine precision and such knowledge with wisdom that there is no reason why any man should be ashamed to own a pair, which is a bit funny, but I thought I would share that. So we're going to talk, to be just an overview of the basic structure and function, then we'll go into the renal replacement therapies, the principles, indications, timing, and current consensus. The references are in the individual slides. So Dr. Winnie already took us through the basic unit, the basic functional unit of the kidney. As you can see that there, I will not talk much about it. Now, the functions of the kidneys are numerous. And when we say renal replacement therapy, you're really bragging a bit because you can't do some of the vital functions the kidneys do. It's just more of supportive therapy rather than replacement, especially the hormonal stuff, regulation of vascular resistance, the gluconeogenesis, and so many other things. So the different modalities of renal replacement therapy, and these include peritoneal dialysis, which we rarely do acutely in the ICU, but some have done it. And then there's what we are more familiar with, the intermittent hemodialysis, IHD. And typically that, you take off large volumes over a short period of time. These usually run over 2 to 4 hours. And they use high blood flow rates, sucking quite a bit of blood from the patient per minute, 300, 400, sometimes even 500 mils if tolerated. So it's more of episodic solid removal. Therefore, it's inferior when it comes to clearance of uremic toxins and acid base versus the continuous renal replacement therapies. Then CRT is what is recommended and what is mostly done in high-income countries anyway, especially for critically ill patients, because they're just hemodynamically unstable, or there's a lot of things that need fine-tuning, and the patient may not be able to tolerate if done too rapidly. So it's preferable, especially for patients with unstable hemodynamics, those in whom you are worried about cerebral edema, if you want to take off large volumes of fluid, because it's easier to take off larger volumes over a longer period of time, because it runs 24 hours, it's supposed to run 24 hours anyway. And then those with persistent acidosis, there's also better control of that. And then, of course, we have the hybrid techniques, which we commonly use in our settings due to resource limitations. It's hard to do CRT. You need a dedicated nurse to run the machine and be able to understand what the different alarms mean and how to, troubleshoot. And then, of course, the consumables as well. It's quite expensive. So we tend to go to the hybrid, which is the scarf that is slow, continuous ultrafiltration. They are basically focusing on taking off fluid. Though you still get some solute off via solvent drug, but it's mostly filtration. And then there's the slow, low efficiency daily dialysis, which we commonly do in our ICUs for unstable patients. These runs, instead of the 2 to 4 hours of IHD, go 6-8 hours of just slow dialysis. Because patients are unstable and on vasopressors, though the ideal would be CRT. And then, of course, there is plasmapheresis, though it's typically not related to the kidneys per se, but for autoimmune stuff where you want to scrub out the antibodies causing the problem, autoantibodies typically. Okay, sorry. So the basic principles, removal of unwanted solutes or water, and it happens via semi-permeable membrane, which may be cellulose-based or synthetic. And that's important because there's the issue of biocompatibility. The less biocompatible the membrane is, then the more it will activate the complement cascade and worsen inflammation actually for some patients. Then there's also water removal via ultrafiltration, and we'll talk a bit more about these in the subsequent slides. So solid removal is basically via diffusion or convection. So diffusion is the dialysis and convection is a hemofiltration component. So this is a depiction of a dialyzer membrane. It's like millions of hollow fibers packed in that cylinder to act as a membrane across which diffusion can occur or filtration. So in the convection process, you see blood comes in from, what side is that? The left side of the screen. So it's coming into the filter. And then, so above there, as it runs through, the hydrostatic pressure in the blood, sometimes we add replacement fluid to dilute it further and to enable the toxins come off the red blood cells a bit better. So the hydrostatic pressure that builds in there is much higher than on the other end of the filter. So that pushes fluid, water, it filters the plasma, in other words, and as that mass movement occurs, it goes along with some solids, both small and middle molecules. So this is actually very good for clearance of middle molecular weight solids, as opposed to diffusion on the lower part of that slide. So in diffusion, blood is still going through the membrane, but it's diffusion, as we know from basic chemistry and sciences, it depends on a concentration gradient. So what we do is run the dialysate fluid. So you can see that we run a certain fluid, which you call the dialysate, to run through in an opposite direction with the blood. That's countercurrent flow to sort of maintain that concentration gradient between the solids you are interested in removing. So this is usually for small molecules like hydrogen ions, potassium, and other electrolytes. It's not very good with middle molecular weight solid removal because of the pore sizes. They limit the size of the molecules that can cross, which is sort of similar to what happens in the Bowman's capsule. When do we actually need to initiate renal replacement therapy? Dr. Wasa has talked about the medical management, and sometimes that fails. It's refractory. So you're pushed to initiate this kind of intervention. So refractory hyperkalemia, volume overload, patient is in pulmonary edema, uremia, though a high urea alone is not really an indication for renal replacement therapy, unless you think it's the one causing, like if the patient is encephalopathic, it's bleeding, or has pericarditis, nausea and vomiting, like those kinds of things, then it's worthwhile to give them dialysis to see if that solves the problem. And then there's, of course, the acidosis, and then there's intoxications. There are some drugs that are dialysable and those that are not. So if someone has poisoning from methotrexate, metformin, and then there's a toxic alcohols, ethylene glycol, methanol, lithium, and so many others, including valproic acid. So in those cases, yes, dialysis would help to get the toxins out of the body faster. And then in some instances, severe heart failure with a reduced ejection fraction, where you have congestive hepatopathy and renal failure from the renal vascular congestion, doing dialysis to take the extra fluid off would actually help restore the balance so that homeostasis is restored and things go back to working as they should. Another, I guess, uncommon here, but in some cases, when people have severe hyperthermia, could be from NMS or some other drugs, especially CRT. I'm not very certain about IHD, but you can adjust the temperature. So you can cool the patient's blood that way by just getting the blood to run through a cold extracorporeal circuit and giving it back. Same thing for hypothermia, you can warm them that way. But those are a bit sort of out there indications. So those are the typically urgent indications for dialysis. Then in people with end-stage renal disease, what I've seen is usually, Dr. Kalesula can maybe talk about this, comment about this for clarity, but typically GFRs less than 10 to 20. And I used to wonder why they delayed starting dialysis, but apparently you can't live very long on dialysis. There's a time limit. I don't think they go beyond 15 years, 15 or 20. So they delay it as much as possible, as much as is safe, even though they know the kidneys are getting worse before they actually start chronic dialysis. And then of course, severe AKI, even if you don't have the indications, but it's just not getting better, and sometimes you need to intervene. So I guess this is a common picture of what we see in the ICU. I mean, for venous access, you need a large bore catheter. The KDIGO recommends the right internal jugular vein as first line for access, if possible, just better flows. And then if that is not possible, FEM is recommended. Then left IJ subclavian is last choice because first of all, they tend to stenose, and then if their kidney function doesn't recover, they may need that site for permanent catheter insertion. So it's better to go right IJ or FEM. So blood, so it's a dual lumen. One port is the access, the other one is the return. So blood comes out, goes through a pump. The pump helps to promote forward flow. So this is a CRRT kind of scenario. Replacement fluid is added to the blood coming from the patient before it goes through the filter. That helps prolong filter life, along with improved clearance of some toxins. And then there's dialysate fluid that's pumped through that membrane as well, in the opposite, countercurrent to the blood flow. Though sometimes, depending on the patient's condition and what your targets are, sometimes the dialysate fluid can be run concurrently. And then the effluent comes out. The effluent here is the sum of the ultrafiltrate and the spent dialysate here, as we saw from that diagram. So this tries to go a bit further into what's going on, but I don't know if you're interested in. Anyway, so blood coming in from the patient, you may decide to add anticoagulant here. If a patient is systemically anticoagulated, you may not need to do this, but sometimes if a patient is bleeding, you may need to do regional anticoagulation, meaning within the circuit, just so that the filter doesn't clot. Otherwise, you keep having to replace and it will be inefficient. So you can add either citrate or heparin, unfractionated heparin. Those are the two most commonly used, because you can easily reverse them at the end before the blood goes back into the patient. And so there's all these pressure gauges. So there's the access pressure gauge. If the flow is too sluggish from the patient, let's say, and it's not meeting what you've set into the machine to suck, I don't know, for lack of a better word, to draw it, then it will alarm excessive negative pressure, or sometimes it's just the catheter that has got a problem and needs to be changed. Anyway, so this is pre-dilution. So this replacement fluid can be given pre-dilution or post-dilution or both, in varying ratios, depending on what you're trying to achieve. There's another pressure gauge for the filter, because as the filter ages or clotting goes on in there, then it becomes, the pressure there starts to rise and the process is no longer effective in terms of solute removal. So then on the other end, you can reverse. So we've already talked about the dialysate part. The part that there's a pump that brings in dialysate fluid, runs concurrently, typically, and then back into the effluent bag. Okay, I'm going to proceed. This is a photo of a CRT monitor. So typically for CRT, we run, we draw smaller volumes of blood, like the blood flow rates are less than for IHD because the patients are less stable. So typically around 200, at most usually about 300 mils per minute. And then that you can see when it comes to dosing, the dialysate and replacement fluid are dosed in a 1-to-1 ratio. And the dose for CRT is actually calculated as an effluent dose. And we'll talk about what the recommended is, but typically between 20 and 30 mils per kilo per hour. And then you split that 1-to-1, and then, you feed that into the machine and provide the bags. So we've talked about hemofiltration, we've talked about the dialysis. I think we've done all that. So 60% of patients in the ICU will get AKI, and 2/3 of those will end up needing renal replacement therapy. So the modality of choice depends on the patient's status and what the unit is capable of providing. So the advantages of fluid management, you can take off a larger volume of fluid, and then also better clearance of middle molecular weight, substances like inflammatory mediators, and that's why you can also use it to do like plasmapheresis. Sorry, not CRT per se, but there was that concept, the idea that it was preferable in sepsis because it takes out the inflammatory mediators better. But though we'll see from a trial that did this, there was really no benefit per se. And then, of course, cerebral perfusion. If you heard about cerebral perfusion, it's better you go with a gentler approach, which is CRT than IHD. So the timing of initiation has been investigated by several trials of when to start renal replacement therapy for severe AKI in ICU. So there was the Elaine trial, the Aki 2, the START AKI that Dr. Asa has talked about, the IDEAL ICU, and many others. I'll talk a bit more about them later on. So, but in terms of indications for dialysis, this was from the International Journal of Nephrology. It was actually conducted by nephrologists, and they're looking at common indications for initiation of renal replacement therapy between patients in the ICU versus outside ICU. And then, there's a few things that differ, but as you can see, 74%, almost 75% indication for initiation in ICU was metabolic and fluid demand to capacity imbalance, which was also the biggest percentage outside the ICU. However, uremia was more common outside than in the ICU. And then in terms of dialysis methods used CRT, of course, is more commonly used in the ICU than outside the ICU. And then prolonged hemodialysis was also more in the ICU because patients are just sick. Peritoneal dialysis, as you can see here, is less often chosen for ICU patients versus outpatients. Though there is a study that has reported about that I'll mention later on. So, I just wanted to highlight a bit of the components of the hemodialysis, the dialysate fluids. So for dialysis, you have the electrolytes, maybe lactate based or bicarb based in terms of the buffers. From this excerpt, it was mostly bicarb. So you, depending on the patient's bicarb, you can choose what concentration of bicarb you're going to run, what bath of bicarb. And then when it comes to the sodium is also variable. You choose depending on the patient's sodium. And then when it comes to peritoneal dialysis, the dialysate fluid, the dialysate fluid has more glucose, dextrose, because that is what you're using actually to draw fluid into the peritoneal cavity. So there is challenge associated with this intervention. Of course, it's not risk-free like many things in medicine. So the anticoagulation, typically citrate versus unfractionated heparin. And so sometimes the citrate may go systemic and cause, hypocalcemia. So it needs frequent monitoring of calcium levels. You may check pre and post filter to see, but you need to be able to run electrolytes regularly when you're using citrate. You can use unfractionated heparin, and that may be systemic or regional, like just within the circuit. And with the associated, risks associated that come with that. Risk of heat is the same. May need to reverse it with protamine. They may end up bleeding. So then, of course, there's vascular access related issues, stenosis, sepsis, injury. And then, of course, especially with CRT, it is quite intensive, human resource intensive. Like Eras was mentioning in the chat, you may need to send a dialysis nurse along with the patient. Then it's definitely more expensive in terms of consumables. And then, of course, the rapid fluid shifts and solute concentration changes may affect some patients. There's also still a risk of the dialysis disequilibrium syndrome. And then the compatibility issues with the membrane. We also need to remember that there's loss of nutrients, both micro and macro. So we need to replace these when patients are on dialysis. They lose amino acids, vitamins, so they need to be on selenium, Renavite, and all those things. So in terms of anticoagulation, so sometimes if a patient is very high, like if they're bleeding, you may not want to tamper at all with any anticoagulants. But then there is a risk that the filter will clot and age rapidly. So you have to stop the session and change the filter. The patient ends up losing the blood in the circuit. So it's messy. So sometimes what you do is just do the regional anticoagulation that we talked about. You give the heparin pre-filter and give them protamine post-filter. So the blood that goes back into the patient is heparin-free. There's other things you can use. Especially for people who get heat, you can use agatroban. I don't know how available that is, but low molecular weight is really not the best because unless you have the antidotes, it's renally cleared. But we know some of these functions of the kidneys, dialysis doesn't do very well. So it's best to stick with something that's shorter acting and easily reversible. So in terms of dosing for renal replacement therapy, for IHD, we use urea kinetics. But of course, with CRT, things are so dynamic. It's hard to calculate the effectiveness using urea kinetics, mostly because they use, the target is this KT to VD. The K is urea clearance. T is time of dialysis, or duration of dialysis, while the VD is the volume of distribution of urea. And we know in critically ill patients, it's very hard to estimate the volume of distribution. We know it increases typically, but it's hard to work out exactly what it is. And the target is that it should be above 1, meaning that the entire blood volume has been cleared of urea, at least. How do I say it? I think in another term, in a certain study, they were talking about a urea reduction rate of about 58% is the target, and that was associated with improved outcomes. Now, urea, I mean, it's just something we can easily measure, but it's not really exactly that. It's not the best to use in terms of assessing effectiveness of the therapy. In CRT, we talked about the dosing. We used effluent rate, 20 to 30 mils per kilo per hour, and that is the delivered dose. So that is what you prescribe. I mean, you may prescribe 25 mils per kilo per hour, and because of having to change a filter, having to move a patient to imaging for, to like transport a patient for imaging, they may end up not really being on CRT for 24 hours. So that delivered dose may differ significantly from the prescribed dose. But we know at least from the Renault trial, which was, I think, the largest, looking at what's the optimal dose for CRT in particular, they compare 25 mils per kilo per hour versus 40 mils per kilo per hour, and there was no survival benefit. There was no, the higher dose, the more intensive dose had more complications in terms of hypophosphatemia, hypokalemia, and such things, but the mortality did not change. But you also definitely don't want to go below 20 mils per kilo per hour, because then that is underdosing and you will not be as effective. So in CRT, the best monitor really would be to look at the urea concentration in the effluent versus blood. So the ratio should be about 1. They should equilibrate. And as the filter life goes down or becomes clogged and less useful, the ratio changes. The one in blood will be much higher than the one in the effluent, meaning you're not really effectively clearing the solids. And then in the hybrid, some studies were looking at BUN for 56 to 70 pre-dialysis. That is for people who are getting daily runs of, let's say, SLED. The morning BUN they were targeting was less than 70. With CRT, typically around steady state, BUN may range between 10 to 20. And that's when you can try and actually use formula to work out the effectiveness. But yeah. So this was an observational study from 2021. Look, at that time when, at the height of the pandemic, when in high-income countries are also like stretched thin and they provide CRT for all patients with AKI. So some centers actually tried peritoneal dialysis, and it seemed to work for these patients. So I think it's doable. So this was the people with AKI alone. They found were for patients with obesity, it was a bit harder to put, because the PD pods had to be inserted bedside. So risk of damaging the gut or intra-abdominal viscera was higher, especially when they're obese. And then, of course, you think about if you have to prone them, then yet you've put the dialysate fluid in their abdomen, there's a risk of them getting abdominal compartment syndrome. But otherwise, it's doable, and it is an option in adults. Yeah, but the problem, the sample size was very small. I mean, the patients who actually got PD were 37, 11% died. 29%, which is not surprising, given what we know about the mortality risk associated with AKI. But, and then, yeah, it shows you median PD catheter use per patient, 8 days. Median days, the PD catheter was in situ 9 days, and then time to recovery. It's an interesting paper. It's worth reading. This is from a review article from 2021. Yeah, they were trying to look at comparing these studies that have been trying to look at the timing of initiating renal replacement therapy in ICU. The Elaine trial, that's from 2016, as well as the Aki one. The Elaine trial was single center, and they were mostly surgical patients, post-cardiac surgery. They recruited patients at critical stage 2, so they were a bit less severe, less severity of renal injury, who are critically ill. So, but then they found, and for them, they actually, so they were looking at early versus delayed, right? So intervention early, those who in the early group, those who are randomized to the early group got renal replacement therapy initiated within 8 hours of randomization versus 12 hours for the delayed group. And they found mortality benefit, which was a bit unbelievable. So at 90 days, 39% in the early versus 54% in the delayed. But it was a bit weird because this advantage wasn't seen at 28 days or 30 days. It only came out at 90 days. And then, of course, the fragility index was quite high. Is it high or low? And it was 3, meaning just changing the outcome. So 3 patients would make the finding null and void. So that is why people came out to do larger studies to try and answer that particular question. So the Aki was multi-center, it is French. The Elaine, I think, was in Germany. So the Aki also looked at early versus delayed, and for them, early started dialysis within 6 hours of randomization, while delayed, they waited for patients to develop absolute indications for dialysis, meaning acidosis, urea, and they gave good cutoffs there indicated. Or if the severe AKI persisted for more than 72 hours. So, for that, you see that the number that ended up needing or starting renal replacement therapy was 51%. So meaning there's the 40 something were able to get renal recovery as they waited it out with medical management. So the ideal ICU is another trial, but this one was looking at patients with septic shock and AKI in particular, and they were using the RIFO criteria. The only problem, so for them, early versus delayed, they started dialysis within 12 hours of the failure stage versus waiting 48 hours or till a patient gets absolute indications for dialysis. And even then you see that with that 62%, only 62% got dialysis in the delayed group versus almost like 98, like almost 100% in the early group. So it does with no, and all these with no mortality difference. So that tells you that if someone gets, someone gets severe AKI in the ICU, it's as long as there is no absolute indication to start dialysis, like a life-threatening thing, it is okay to wait at least up to 72 hours. However, the ideal study was stopped early. Hello?
Dr. Mata, if you could just summarize over the next 3 to 4 minutes now.
Yeah.
We're running out of time. Thank you.
Yeah, I'm almost done. So the only problem with that is it was stopped early due to futility, though then it ended up being underpowered. So I will not talk about the START trial that I already talked about, but there is the Aki 2 trial, which is from this year, last year, sorry. But this is the most recent, and they're trying to answer the question of how long can you wait safely before starting initiating renal replacement therapy in patients with severe AKI in the ICU. So they looked at 72 hours was the delayed strategy group, and then the more delayed was more than 72 hours as long as they didn't have indications. And they found that it was actually harmful. I mean, the hazard ratio for death at 60 days was 1.65 in the more delayed strategy. So I think 72 hours is where most of us are comfortable waiting, and then we go ahead and initiate our renal replacement therapy if the patient doesn't show signs of turning around. So this is a schematic, sort of something to guide you on when should we start renal replacement therapy. Yeah, it's most of the things we've talked about, so it's just a summary in there. So thank you very much. Yeah, questions and comments are welcome.
Thank you very much, Dr. Mata. That's quite a rich, fat topic, and we shall never really stop conversing about this because there's a lot of information coming around. There's a lot of experiences to be shared, but you try to put it all together in just a few minutes, really. Again, to the audience, these are meant to stimulate you to 1, go study more, 2, review your own practices, and 3, continue improving. The conversations have to continue to keep us improving. So at this point, I would like to welcome maybe 2 hot questions to the members, to the presenters. Some questions in the chat have already been answered, so we shall not be going back to them. Anyone with some hot questions? All right, so I hate to keep you guys here for too long. We have had quite a protracted run on this particular topic, and we've gone 1 hour beyond our usual time, and I apologize for that. The topics, unfortunately, are very fat. I'm happy that you're able to maintain your concentration. Next week, we are going to be tackling something to do with electrolyte imbalance, that is hyponatremia in the ICU and hypernatremia in the ICU. Again, come back with your keen eyes and you go and read about the topics, so that you have more questions to submit. And for those who are interested in presenting, kindly inbox me. For those I did not consider for the previous, for this talk, you will be given priority for the next talk. Continue volunteering. Thank you so much for participating. For any further questions, you can reach out to the presenters, reach out to myself, Dr. Cornelius, Dr. Kaliasubula, for any expert input on some of the topics. I thank you so much for your audience and wish you a great night. Enjoy your weekend. Bye-bye.